If we have an IC, if I'm telling you your ICP is 20, well, I want you to think danger. I want you to think, oh my God, all those things are going to explode out of that skull. Do not let your patient go above 20 for too long. If they are at an ICP of over 20 for like 6 minutes, that's going to be cutting off blood flow, all kinds of crazy things in your head. Your head cannot perform under that much pressure. So that is a key point. Don't put the ICP. The ICP is not allowed to go over 20. The map, we already talked a little bit about the map in cardiac. How do you feel about that? You're never going to have to calculate it. I'm going to give it to you if you don't know where it is. The mean arterial pressure is in the parentheses after your blood pressure. So every mechanical, you won't get the map. You'll have to calculate it if you do a manual blood pressure. Otherwise, you will always get your mean arterial pressure in the parentheses next to your blood pressure. The important thing to remember on a mean arterial pressure is that the minimum of it needs to be at least 60. That is the pressure that takes to get your heart to pump pressure up into your brain space. You need a pressure of at least 60 to get blood up into your brain space, okay? You don't want your mean arterial pressure to go over 100. That's too much pressure going up into the brain space. So again, when we're managing the brain, we want enough pressure to get up there, but not too much, okay? So this is why when your patient gets hypertensive, we don't like seeing means of 103, 110, 112. That means we're putting a lot of pressure up to the brain. That means blood's going up to the brain in great, big, strong boluses. This fluid's been flowing through these blood vessels at very high pressure. They're at very high risk of bursting and bleeding more. So we want to keep our means minimum. If you're having blood pressure problems, we are always looking to keep that blood pressure mean at least 60. So we can say we have enough to perfuse the brain. We want to keep it below 100 because that's too much pressure for the brain. So that's where normally our blood pressure does sit with a mean of 60 to 100. But when we are in the ICU and we're using vasopressors to bring their blood pressure up, they're usually titrating it to this minimum arterial pressure. Sometimes you'll see them trying to keep the map of 65 because that's even better. If the minimum 60, let's do a little better for this patient. Let's make sure that they're getting their blood flow. So all you need to know about map is where to read it and what the normals are, okay? Then the other part of it is the cerebral perfusion pressure. And to get a cerebral perfusion pressure, we need an ICP and a map. So you cannot get a cerebral perfusion pressure unless you have an intracranial pressure. The only way to get an intracranial pressure is to literally monitor it. So we don't usually do this calculation very often, but if your patient has an intracranial pressure monitor and you have that ICP number, then you will start doing a cerebral perfusion pressure monitoring. And this is to make sure we assume that this is what the pressure is going up to the brain. That's for a normal brain. We're assuming that 60 is the minimum pressure to get up to the brain in a brain that's not under pressure. So it takes the heart, and I'm not going to go back to the camera, but this takes the heart 60 millimeters of mercury to push blood from here to here, okay, in a brain that's not under pressure. If we start putting this brain under pressure, let's put a couple more things in here. Let's see what else we can put in there. Let's put some more, let's see, I have fluid. Well, we'll put him under pressure, but let's imagine that this brain is under pressure now. So it took 60 millimeters of pressure to get blood up into this space when there was no pressure in it. Now we've got pressure. Do you think you're going to need more or less pumping from the heart, more or less strength from the heart to get blood into a brain under pressure? A lot more. So that is what the cerebral perfusion pressure does, is it takes the intracranial pressure into account. So it's saying that if your map, let's draw a thing over here. If your mean arterial pressure is, let's say 62, and you know you have an intracranial pressure of 15, because you got a monitor in and they're worried about it. We're going to take our we're going to find our cerebral perfusion pressure by taking our mean arterial pressure and subtracting the ICP from it. because this is an increased amount of pressure that we're having to deal with. So we take with 62 minus 15. That's, what is it? 47. Is that an accurate, is that enough to get up there? No. So even though the mean may be okay, because it's having to push up against extra pressure, it turns out to be pretty weak. So we have to decide, once the brain is under pressure, we have to pump up the heart a little bit to push harder up to the brain. So when the brain's under pressure, the cerebral perfusion pressure becomes important. We will assume in a patient without brain issues that the MAP is our cerebral perfusion pressure. MAP is cerebral perfusion pressure. Your mean arterial pressure is your cerebral perfusion pressure if your brain is normal. If your brain is under pressure, then we need to move to the cerebral perfusion pressure, okay? Because we would want to increase the MAP to what? To keep this efficient. If we want to get a minimum cerebral perfusion pressure of 60, what does our mean need to be? Our mean needs to be 75 or higher, right? So that becomes a very different patient now. And neuro patients may have their blood pressure artificially elevated to try to get enough blood flow to the brain. We just want to get this minimum perfusion pressure of 60. But when the brain is under pressure, we may have to amp up the heart a little bit to get it to push that blood up. So in the brain injured patient, we may be making the heart work harder. This will be much harder to do if your patient's in heart failure and has a brain injury. We might not be able to get the heart to do this, but we're hoping our patients, most brain injured patients are not heart failure patients. But we want our mean to be 75, and that's just because brains under pressure require more pressure to go up. So we don't need to worry about cerebral perfusion pressure unless we're monitoring the intracranial pressure. And if our intracranial pressures are high, we're going to need to up our blood pressure. Does that make sense to everybody? So those are the three things. And again, danger zone is 60 millimeters. We want to keep 60 millimeters of pressure going up to the brain. If you have an ICP measurement, you're going to have to do a calculation, MAP minus ICP, to get the perfusion pressure. If you don't have an intracranial pressure, we'll just take MAP as your perfusion pressure, okay? Cerebral spinal fluid, this is just one more thing. Just because we can draw it and measure it, where do we draw it from? How do we get the cerebral spinal? Do we go up into the brain and grab it? We're going to get it from the spinal cord, because remember, this CSF is also coming down out of that hole and circulating around the spinal cord. It's all one big continuous system. That dura mater continues all the way down through our spinal cord, and that CSF circulates around the spinal cord, back up and back down and back up. And so it's a nice little highway of Cushing all around our spinal cord and our brain. So yeah, we don't usually poke into your brain to go in and get your cerebral spinal fluid. Because it circulates around our spine, we can go into the spine and pull out the cerebral spinal fluid. It's the same cerebral spinal fluid that's in our brain. So if we want to take a look at the cerebral spinal fluid, that's where they pull it from, is the spine, because we're not going to poke the head to get something out of there. You do not need to memorize these. These come into play when we are measuring the CSF and seeing if the CSF is normal. One thing to point out is that CSF has a lot of glucose in it. That's part of the nourishment of the brain. The brain uses 80% of the glucose that we take in. That's a lot of glucose. The brain is glucose and oxygen needy. It's our most needy consuming organ in our body, and it consumes glucose and oxygen. So glucose will be circulating around in the cerebral spinal fluid, and it also comes up in your blood vessels. But there's a lot of glucose in cerebral spinal fluid. It's very thick, it's hypertonic. There's also protein in it. There should not be red or white blood cells in it. It should be clear. Cerebral spinal fluid is clear, and it's made, and it carries around a ton of sugar and protein in it. So those are the nice to know there. And then we have a lot of testing for neuro. It's all going down to a test. So every neuro patient, you're going to get to push that bed a lot. Neuro patients, you know, we have to look in there somehow. How do we look into the chest? Chest x-ray, CT scan, same thing. Chest x-ray, CT scans, now head x-rays and CT scans. But there is no real head x-ray. We can look at the bones with an x-ray, but you can't look at tissues with x-ray, right? X-ray is great for air and bone. But a lot of the stuff that we're looking at in the brain, we don't care about the bone. We want to know about the tissue. So to get into the tissue, we have to look at some other things. So we don't do head x-rays because that'll just tell us whether our bone is broken or not. Doesn't tell us anything about our brain. We cannot visualize with an x-ray the tissue of the brain. So a CT scan is usually our first test. There are CT scans with or without contrast. What's the difference? One's crisper than the other. That's it. Contrast has so many side effects. Remember, you can't be allergic to iodine, shellfish. Also, it's kidney toxic. And most brain patients, we're doing this daily, just like patients with lung problems, they're getting daily chest x-rays. With head patients, they're getting daily CT scans. So we don't want to be putting contrast into their system every day. And so they can get most of the information they need from a CT scan, a quick view of the brain and the tissues. If you need detailed view of the tissues, you have to get an MRI. MRIs take longer, have more limitations on them, have a longer wait list. Have you had a patient have an MRI at the hospital? Has anybody gone down for the MRI? How long did it take them to wait? How long were they waiting for it?
Last week.
2 hours, 2 days, 2 hours? That's pretty dang good. That must have been emergent.
From the EVs, that's pretty quick.
Yeah. So most patients can't get an MRI for a couple of days. If it's not emergent, they will just go down their list. And so MRIs are generally, because they take longer, these are like hour and a half exams, plus you can't take anything into the MRI room. They need all specialized equipment. So there's take down, get them ready to go in the room. So even though the MRI takes an hour, getting them ready to go into the MRI and then come out of the MRI is another half hour. So this becomes like a 2 or 3 hour road trip to go to MRI sometimes. So the CT scan's quicker, easier. But it's not very detailed of the brain tissue. You can see definitely the difference here. If this is brain tissue, it's much clearer and crisper. So if they want to see details of the tissue and what's going on with the tissues, they need an MRI. Same as if a hand, you can get a CT scan, but if they want details, they're going to the MRI. So we do those. CT scans are standard. It's usually without contrast because we don't want to keep loading up on contrast, but they can order contrast. The MRI is definitely more detailed. We'll give you much more detailed images of the bones and the tissue. PET scans are activity. That's reading all the electricity and neurotransmitter conduction around the brain. So whereas the CT scan and the MRI just tell you what does the tissue look like. This tells you how the tissue is functioning. Okay, so the PET scan is good for tissue function. This is for tissue anatomy, CT and MRI. Tissue function is basically where we can see, they will do this on patients where this isn't really an in-hospital, emergent thing for injuries. But we can see that this area of the brain is way more active than this area of the brain. So they will do that to compare and contrast people and trying to find out if their tissues are functional or not. They can go to a PET scan. And then the angiogram is just like a heart cath. It's a brain cath. It's where we're looking at the blood flow around the brain. Here you can see the carotids coming up. You can kind of see the circle of Willis there. And then we got the posterior, anterior, and middle cerebral arteries going up there. So you can do an angiogram. It's the same as going to a cath lab. It's just called an angiogram, but they are still putting in a dye, and they are taking a catheter up and they're shooting dye into the brain and looking at the brain. It's the same as when we're doing a cath lab for a patient and we're getting the camera into the cardiac blood vessels and then shooting dye around the cardiac blood vessels. Same thing. They can do the same interventions in the head that they can do in the heart. So they can stent open blood vessels, they can balloon open blood vessels, they can cauterize any aneurysms. They can do all the same things to the brain that they can do to the heart. It's just called cerebral angiogram instead of cardiac procedure, percutaneous coronary intervention, it will be called a cerebral angiogram. But they are still the same thing. It's the blood flow around the brain. So those are your testings that we will do. So what you would need to know is probably your first test that they're going to do quickly are going to be the CT scans, and then all the others for detail. This is nice to know. I won't ask you specific questions on where are these fields. I think this is useful for when you are taking care of a patient and seeing where, whenever those recognized cues say localized deficits, this is what we're kind of talking about here. When we're talking about localized deficits, if you're having a change in your neuro exam, it's usually located to some part of the brain that controls that function. So you don't have to memorize this list. It's just nice to know what each lobe kind of does. So that will help you see if your patient is having trouble following commands, they might have some ischemia or some pressure or some blood, or there's some problem around their temporal lobe. And so I'm not going to make you memorize this because you'll get a CT scan that will tell you exactly where the pressure is or where the insults are, but you can match them to your neuro exam. So if someone had I think there was a dearth of basal ganglia issues on D. I'm not really sure why. There were so many basal ganglia bleeds. And so I was like, all right, well, where's our basal ganglia? Our basal ganglia is up here in the temporal lobe, and it is part of, it does complex movements, it does some perception. So it is sitting, the basal ganglia, it's not even right here, it sits right in the middle here between the temporal and the parietal lobe, and it does all your complex movements, and that's actually where Parkinson's originates as well, as in your basal ganglia. But these patients would have basal ganglia infarcts or basal ganglia bleeds. So what is that going to do to your neuro assessment? You're going to be having problems with your temporal parietal lobes because that's where the basal ganglia is located. Might not be full damage to those lobes, but those areas around it are going to be impacted. So you may see that patients with those basal ganglia infarcts are having trouble with speech or maybe following commands or their orientation because that's the area of the brain that's kind of gotten damaged. So when you see your charts, communicate if they do have the lobes that are damaged or the areas of the brains that are damaged, try to correlate that to your neuro assessment. It's just nice to know. I'm not going to say, there's not going to be a select all that apply that say which ones are on the parietal lobe. I'm not going to directly test you because again, this is stuff that it's kind of nice to know. It's not, the interventions are where we're going to go. So these are all nice to know things that I may say your patient had an infarct in the right temporal lobe. And then I would give you the findings, but I want you to be like, oh, well, temporal lobe is speech and understanding, so they might have some speech deficits. That wouldn't be surprising. That wouldn't be a worsening cue. That's an expected cue. They had damage to that area. They're not going to be able to function in that area very well. So that helps you understand some chart terms. But this also tells you when you do the neuro exam what lobe you're testing. Kind of nice to know what you're assessing when you're assessing something. So this will, what I want you to focus on is this. Yes, there will be cranial nerve questions. Yay! Yes, there will be cranial nerve questions. Mostly how to test it. I'm not interested in the fact that you know that it's named to the olfactory nerve. Don't really care, but how do you test the olfactory nerve? Because that's what you're going to be doing. You're going to be doing the assessments. So I want you to know how to test them. If they say they have a cranial nerve 8 deficit, what did you test? You tested hearing. So this is where you got to go back to block 1. I know you remember the head to toe assessment. You did the head to toe assessment. Did you do it in block 1 or did she say, now you wait till 4? Here it is. Yay! We are going to do this cranial nerve assessment. So I'm going to point out to you the kind of questions that I will ask you. I think, are they on here? I think it's in the, let's go to a couple of these. It's in, where's our, sorry, let's get back to our class. And I will show you where you can practice your spinal cord assessment. I would 100% like, let's see, where's this one? There's demos of them. There's a Glasgow Coma scale practice. Let's go here. ABG Ninja is great. You can practice a whole lot of things on there. I'm going to show you the Glasgow Coma scale next. They have a cranial nerve exam one. Have you ever seen all these things on ABG Ninja? If you go out to the front of ABG Ninja, you not only have you have rhythms, you have all this stuff, but let's go to cranial nerves. So you can look at the cranial nerves and it will go through, mine will always say the number as well as the Roman numeral. Someone told me a couple blocks ago, they're like, learned Roman numerals. I'm like, what? And then I went home and I told my kids, I was like, do you learn Roman numerals? And they're like, no. And I was like, oh my gosh, they're not teaching Roman numerals anymore. That's the standard way that cranial nerves are written. But I will always write 9 next to it so that you will know. You don't have to know cranial nerve, no, Roman numerals. I will write 9 in parentheses next to it. So you might need a little if you're using these. But this is a great, what is the function of cranial nerve 9? I'm going to tell you my shortcuts to it, but then you can go through and do some of these things to get you a little more comfortable with the cranial nerves. But I'm going to tell you my short assessment, and then we'll take a quick break. We're just going through the assessment parts, and then we'll go into the interventions. But yes, you will need to know how to manage these. I like these. I don't know quite where it came from. Some of them are mine that I've developed over time. It goes mostly with that numbered face over there. But number 1, you only have one nose. So cranial nerve 1 is 1. It's an olfactory. It's nose. It's smell. Cranial nerve 2, you have 2 eyes. So that one is vision. Things like, can you see straight? Can you see double? Do you have blurring? My cranial nerve 2 is messed up if I don't have my glasses on. I usually will do my cranial, I will show you how I do my exam super quick. But yes, 2, you have 2 eyes. So that is actual sight. 3, 4, 6 makes the eyes do tricks. I love that rhyme. 3, 4, 6 are your eyes moving through the visual fields, up, down, diagonally, and sideways. You don't need to know which ones do which. I'm not going to test you on which ones do which. I don't know why it's squeaking. 3, 4, 6 makes your eyes do tricks. So if you are doing your visual fields, you're testing cranial nerves 3, 4, and 6. Okay, so when you do that whole cranial field assessment, you're doing if you want to know all the way to 3 is up and down. So if your patient is able to look down, but they can't look up, cranial nerve 3 is messed up. If they can't look diagonally, their cranial nerve 4 is messed up. So this is where if you have a patient that you're having them follow, they can look up, they can look down, but they can't look up to the side. That's their cranial nerve 4. And so I would like you to know 3, 4, 6 is the visual field assessment. You don't need to know which way. I don't remember which way. I go to my MAR and click, when I'm doing my assessment, I click on it and I'm like, what does cranial nerve 4 do again? I know if I'm doing my visual field assessments, it's either 3, 4, or 6 that I'm testing. So 1, test the nose. 2, test your vision on whether you can actually see straight. You can see one thing or you're seeing double or blurred. Then 3, 4, 6 is your cranial nerve, all your movements. 5, I always like to think of 5 as like a slap to the face because it's your facial nerve, okay? It is your motor and sensory, so that's why I like to think of it as a 5 because it's 5 fingers. It covers up your face and it will feel if you snick it. But it's the trigeminal nerve. You don't need to know the names of the nerves. I really had no idea that 4 was the trochlear nerve. In practice, I never knew the names of the nerves, but know their numbers and how to test them. 5 is, like I said, to the facial. 6 is part of the 3, 4, 6, makes your eyes do tricks. 7 is also facial. So when we're doing 3 and 5, so basically you've got 1, just if you test their smell. Can you smell this alcohol swab? Can you smell this, peppermint or whatever it is that you're testing cranial nerve 1? If you ask them to read the clock for you, what time is it? You're getting follow commands, but can you see the clock? A lot of patients are like, I can't see the clock, I need my glasses. Oh, That's useful. Good to know. I ask patients if they can see the clock because that tests cranial nerve 3, 4, or 2 for me really quick. And then I can do just the field of vision. And I'm pretty much down with my eyeballs, right? We're done with the eyeball stuff. And I've done 2, 3, 4, 6 by the time I'm done with checking the eye clock and doing the visual fields. Then we are doing the face. I ask them if they can feel me touching them on each side of the face. That would be the sensory part here. You can ask them to clench their teeth. That tests cranial nerve 5. That is the strength and the motor part of 5. It's clenching teeth. We're not looking for symmetry with 5. We're just looking for the strength of the teeth clench. Because this is the sensory part is feeling your whole face, and then the clenching of the teeth is the motor part of 5. So if you're asking them, are you feeling it? Show me your teeth, bite down, show me your teeth. You can do 2 things. You can do 5 and 7, because 7 is symmetry. And we remember symmetry because if you put 2 7s, they are symmetrical. The 7 going this way is symmetrical, mirror side with the 7 going this way. So 7 is symmetry. And so I ask them to show me their teeth because it does 2 things. It does 5 and 7. So why would you not just say, smile and clench your teeth? You got 5 and 7 done. What you're looking for is the strength that they can actually clench their teeth. And that when they do that, they have to smile a little bit, and you're looking for symmetry. Okay? So 5 and 7 can be done together just by saying, smile or show me your teeth. Clench your teeth. You get the symmetry and you get the clench. I would just go with that one. Clench your teeth for me. Smile and clench your teeth. And you've got both because you can see if they go up on one side, down on the other. You'll see the symmetry. You can also look at the eyes for symmetry. One dropping, one not. That's symmetry. Then 8 looks like an ear. You can see the 8's on the side of his head. 8's for hearing. Test hearing by either rubbing their hair next to it or rubbing your fingers next to your ear and just saying, can you, which ear am I rubbing my fingers next to? That's a very easy hearing exam. And then 9 and 10, this is your gag and your swallow. So 9 is making sure your soft palate is all good and held up. And 10 is the actual swallow. I like to think of 9. I only know the name of the 9 because 9 has more than 9 letters. Glossopharyngeal is like a really long word. And I'm like, it's really long. And people say, for Vegas, I'm home. Vegas makes me gag. And so if you're dealing with 9, I always do a quick assessment of 9 and 10 by looking at my patient and looking to see if they're drooling. If your patient is drooling, 9 and 10 is off. And you can do more details. But if your patient is not drooling, they can swallow their spit. They're probably okay. Most patients, if they're not drooling, have a swallow. They're doing okay. But when you test their swallow, when you're doing those cranial, or those, let me just shut this door since it sounds like people are doing things over here. Nobody's in there. So we have the vagal nerve, glossopharyngeal. Again, you can say or you can swallow, but honestly, when my patients are not drooling, I'm like 9 and 10 are intact because they're swallowing. They're swallowing their own spit. It's an easy test. Shrug is spinal accessories. Think about 1 on each shoulder, and you can shrug them off. And then hypoglossal is 12, 1 tongue between 2 teeth. So if that helps you any, those are the little hints that I have over there. 1 nose, 2 eyes, 3, 4, 6 makes the eyes do tricks. 5 and 7 are facial, touch, and symmetry. And then 8 is hearing. 9 and 10 are gag and swallow. 11 and 12, or 11's the shrug. And your tongue sticking out and staying midline is 12. So you can do a real quick neuro exam. I can do a real quick neuro exam by asking the patient, and they just walk in and say, hey, how are you? You doing okay? You doing feel good? Do you mind telling me the time on the clock? 12:30. 12:30. Did you have problems seeing the clock or did you need to go digital? You could see the clock. There weren't 2 of them or anything? Great. All right. I'm just going to take a look. When you are testing, do you know accommodation, what accommodation means. We use those nice little words, pearl. Pearl, do you know what pearl and pearl are? Pearl is pupils equal and reactive to light, right? Pupils equal, round, reactive to light. Pearl is pupils equal, round, reactive to light, and accommodation. So if you don't test accommodation, don't say you tested accommodation. Do we know what it means?
Come to the center.
When you bring something closer, what do your eyes do? What you're watching something in your eyes as you do that. As something gets closer, what are your eyeballs going to do? Are they going to dilate or constrict as something gets closer to you? They dilate. They're trying to see. They're trying to see as something's coming closer, they will open up to try and let more information in. So accommodation is your pupils dilating as you get closer. Okay, that is showing that you are seeing. So that's why they're doing that. A lot of times we don't test accommodation, but you can do that with the same pen that you're going to test the cranial nerve. So I ask them to read the clock for me. If they can't read it, I'm asking them, are you seeing double? Are you seeing blurry? What is the problem with seeing that far? And honestly, if it is around the clock, there are a lot of people that don't know how to read clocks that way. So sometimes I'm like, but a lot of times hospitals, clocks are digital now because a lot of people can't read round clocks. But yeah, that might be something that you just double check. But when you ask them to read something that's far away, remember people might need their glasses, but that's a good cue for you to look for their glasses. But accommodation, you can start by bringing that closer and saying, just follow that. You're watching to make sure that the eyes dilate as they get closer. It doesn't matter if they cross their eyes or not. They don't need to cross their eyes. You're testing whether the pupil is dilating as it gets closer. Then you start looking for the actual pupil range of motion, follow it up, don't move your head. We're looking for the eyeballs to be able to move. So you can go up, down, so you can go any way you want around the box. You can go up, down, you can go diagonal, or you can go, I usually go up, over, down, over, and then back down. You can do it however you want, as long as you're testing up, down, side, and diagonal. Once I finish that thing, then I just say, okay, show me your teeth, punch your teeth. Great, wonderful. Can you feel me touching the cheek? Okay, feel me touching the cheek. All right, show me where I am rubbing. Okay, and perfect. And then I'm going to have you shrug your shoulders and stick out your tongue. Perfect. Okay, it's done. Cranial nerve assessment done. It really doesn't take that long. And try to combine, you can combine 2, 3, 4, 6. You can combine 5, 7, you can combine 9, 10. If she is drooling, I'm going into a little bit more detailed where I say ah, and swallow for me, and then maybe do a swallow test if we're having issues. But if she's not drooling, which you're not, congratulations. I'm pretty sure 9 and 10 are intact, but you can do the extras. But if you start seeing that they're maybe they got some ptosis and some drool, you might need to go in and differentiate 9 and 10 because you do have some trouble swallowing. So that's the cranial nerve. You can do those cranial nerves on ABG Ninja to make sure you have them down right and that you're getting them. And I will always put them like this for my questions, and for the quiz, I will put the number and the Roman numeral. Yes.
To know the sensory and motor too in there, or just the how?
If you know how to test them, you know if they're sensory motor. If you're doing a motor skill, it's a motor. So no, if you're doing a sensory test, you're doing a sensory test. So I'm not going to have you differentiate whether it's sensory or motor. I don't need you to know the names of them. I need you to know the numbers and how to test them and what they mean, because that's the practical skill. The Glasgow Coma scale, again, you probably have seen a whole bunch of things, but basically anytime your patient is not following commands, we do a Glasgow Coma scale. If your patient is not awake, alert, oriented ×4, do a Glasgow Coma scale, because that's the only way to quantitatively say what's going wrong with your patient. You can say somnolent, stuporous, comatose, all those are subjective words that mean nothing. My stuporous is different than Samantha's stuporous. I mean, we just have different ways of categorizing those. So we just go to a standardized number anytime the patient's not following commands, okay? Soon as your patient is following commands, so you're gonna be using this on the floor. And there will be a lot of questions on the GCS. You will not have to memorize the box. I will give you the box. You're going to get the box on every assessment you get on Cerner. You're going to get the numbers. What I need you to use is use the numbers correctly. Okay? So let's talk about some of these numbers and then we'll take a quick break. And believe me, it doesn't take long to go through the end. The interventions are all the same for all the neuro problems. It's easy. But when we're talking about eye response, you're going to give them the best. You're trying to give them the A. You're trying to give them the high score. Give them their best response. Doesn't mean whether they can sustain this response or not, just their best response. So it's really easy to do. If I walk in the room and you open your eyes at me, I know you can open your eyes spontaneously. I'm good. If you open your eyes when I walk in the room, you're great. You're just existing. You can open your eyes. Great. Always opening to speech means any level of speech without touch. So if you guys, somebody had their eyes closed, maybe they're just resting their eyeballs, and I walk over, I'm like, hey, and you open your eyes, great. That's to speech. So the first thing you're going to do is just hopefully they open their eyes on their own. If not, you'll just say, hey, Mr. So-and-so or Mrs. So-and-so. If they open to or hey, it's the same thing, okay? Any speech that they open their eyes, they get a number 3. But they have to have not opened them spontaneously. It has to be their best. Like the only way I can get them to open their eyes is to talk to them. They will not open their eyes unless someone is talking to them. So that means that this patient can't open their eyes unless they're being spoken to, because otherwise you give them, they can open their eyes spontaneously, right? No eye opening in response to pain. This is where the pain is anything from to the purple nurple or whatever you want to do. That's all levels of pain. It should be eyes opening in response to touch. It should be touch, but for some reason it's pain. But that means that I've walked in and I'm like, hey, how you doing? How you doing? Still no eyes open. How you doing? How you doing? No eyes open. Now we're starting to go to something more painful to get them to open their eyes, okay? Nothing to speech, nothing spontaneously. The only way I could get them to open their eyes was to apply some kind of touch, whether that's shaking them awake, which could be just, hey, I had to shake them awake, or I have to sternal rub them and nothing's happening. Pain is a big, most patients should open their eyes to some kind of pain or some kind of response. No eye opening means you can't get them to open their eyes no matter what. I'm going to say one thing about pain. What do we do to get patients to respond? What have you seen in the hospital? Pinching, hurting. You see a lot of pain. You can incite pain a lot of different ways. When we talk about this localized or withdrawal, I'm going to tell you, you will find most effective pain is central pain, something here, because we are looking when they're, because you can do both together. If you have to get them to eye open to pain, what do they then do to respond to that pain? So we'll skip verbal for a minute. Let's just go with this eye opening to pain. We're going to use that response to tell us they can't follow commands, right? Because if we have the eye open to pain, maybe they do. You can ask them, follow commands, squeeze my hand, wiggle your toes, stick out your tongue, whatever you want to do. I mean, honestly, if you've got to do a neuro assessment, sticking out your tongue is a great command to follow. You might as well just do that. They can stick out their tongue for the neuro assessment. They follow commands. You're done. You've got a 6. You don't have to go any further. If they do what they tell you to do, you're great. If they are not following your commands, then you have to figure out where they are in the understanding spectrum. So we will determine whether they localize or withdraw. And the difference from localize and withdrawal is that they try to find the pain stimulus and remove it. Withdrawal means they just react, but they're not trying to remove. So let's say I walk up to someone and I start, squeezing their clavicle because they didn't do anything. I screamed at them, hey, I patted the shoulder, nothing. And so I do a pinch. Now, if you wake up somebody pinching your clavicle, what are you gonna do? You're gonna say, get freak off of me. You're gonna reach to that pain stimulus and make it stop. You're gonna be like, what are you doing? Get off of me. You're gonna reach towards it. If you don't reach towards it, maybe you just flail out, maybe you just kind of make something, maybe you do something, but you're not trying to remove the pain source, that would be a withdrawal. Localized means you found the pain source and you're going for it. A patient who wakes up with a breathing tube in their mouth and they go to pull it out, they're withdrawing to pain. They are going to the pain source and they're trying to remove it. So we are always looking for that. That's one of the things. If you have to go to response to pain, then look at what they do to that pain stimulus. Hopefully we don't have to get too far, to get them to do something, but you do have to go deeper and deeper and keep it central so that you can see whether they're actually moving for it. That's why we don't recommend the fingertip for pain. Because what are they going to do to remove the pain source? They're going to pull their hand away. You don't know if that was localizing to pain or if it was withdrawing to pain. It doesn't tell you. Both are the same. They got rid of the pain source, but that's why we don't use peripheral pain as a source. Usually the pain is something sternal, clavicle, pinching or something, but it's cervical or it's central so that we can see if they try to remove it. That's why nail bed pressure is not a good way to assess pain, because in withdrawal, you don't know which one to give it. Did they withdraw it because that was the pain source and that's appropriate and you should give them localized, or were they just withdrawing it because that was going to be their instinct, whether you did this or toe or finger? Maybe they were just going to pull their hand away no matter what you did. So really, that's why the pain stimulus should be something central, okay? Usually a clavicle pinch or a sternal rub. And you can start a sternal rub gentle and go deeper. I've seen some people that have had the sternal rub used way too much, and they have a giant bruise right here because they don't respond very much. And so every neuro assessment, the nurse is going in and doing sternal pain. Well, we might have to change the pain source. You can pinch the toes because well, no, the toes are the same problem because you don't know if they're withdrawing or pulling. But yeah, usually something here, ears, cartilage pinching, that hurts. If you pinch a cartilage, that'll hurt. So anything that you can do to elicit a response and see where they go, okay, see if they're localizing. So I went over here in a little bit, but obey commands, easy. Localized withdrawal, you do need to do something central to see if they try to reach for the pain source or not. If they're not reaching for the pain source at all, they're not doing anything, there are two abnormal responses that you will only see with severe brain injury, and those will be abnormal flexion and abnormal extension. They look exactly like this. These are brainstem reflexes. These are, you will only see these when there's pressure on the brainstem. You're not doing any more localizing because the pressure in your head is so high that there is no more temporal or motor cortex, and now we're just down to brainstem functions. Yeah.
Is that what they mean with mostly like their posture?
Yes, posturing are these two. Those are the only two postures that are out there for brainstem injuries, and it's these two. So they get called out because if you see these postures, they are a sign of severe brain injury. So the postures are flexion, abnormal flexion, meaning they flex in towards their chest. What they will do is if you apply any pain stimulus, they will flex in. They look like they're just doing their pre-death maneuver, but they are flexioning in. So they cross their hands across their chest and point their toes. That's abnormal flexioning. Okay. Any response to pain. So if you suction the patient, they might do this. They might bring up their hands and point their toes. If they have posturing, you will see this to pain or to suction or anything like that. The other one is extension, and that one looks like they extend their hands and they actually rotate their hands out. So with flexion, they bring them up like this, and with extension, they bring them out and they rotate their hands outwards like this. Both of them have pointed toes. So if you want to call your client posturing, they have to be one of these two. Anything else, we'll just call it localizes to pain or something like that. Those are the only two postures you'll see.
I have a question. So I had a patient like 2 weeks ago that was like a 5 on the scale, and he was doing the posturing, But just on one side, would that like be indicative of how it's possibly like stroke or? something
Yes.
like that?
So if they're posturing on one side, so if one side's doing nothing and one side's doing this, yeah, I would still call it posturing. It's the best response because the other side's doing nothing.
Nothing.
So we'll give them the best score, but if it was extending, then they get a 2. If it was flexing, so you could have a patient that points toes and brings up on just one side.
It was just, yeah, like one arm up and then like bending his knee up like this much.
Yeah, so I'm not sure if we call it full-on posturing because usually the legs are fully extended with a true posturing. So that where sometimes it's confusing because you're like, did you just do that because you're localized, because you're withdrawing to pain? So we will probably give them the benefit of the doubt. If I don't see pointed toes and the extension the right way, I'm not going to give them the posturing. I'll give them withdrawals from pain because I'm like, that's not, the posturing happens this way. That is a anatomical
I mean,
brainstem,
what
yeah.
said he was.
And it could be. Everyone's different. Some nurses might call it posturing. I wouldn't because I don't want to, if his knee bent up, he's not posturing. If his knee bent up, he's not quite there yet because a true posturing would be straight with toes pointed and this and the arm. So you would need both for it to call posturing. So if he bent his knee up, I'm going to go to the next highest and give him a 4 because I'm like, you know what? I don't want you to be posturing. But everyone does it differently. Even the Glasgow Coma scale can be subjective because a lot of people don't catalog, localize, and withdrawing the same way. So it is standardized. That is what it means. Withdrawal means you had to go to the pain source. You have to prove that you know where the pain source is and you can get to it. Whether it's unilateral or bilateral, you know where the pain source is. So you will see that people's Glasgow Coma scales may differ by a point or 2. That's why on most neuro units, they have the nurses do the neuro assessment together at the beginning of the shift to get rid of those subjective issues and that everybody understands what they're doing. Verbal is pretty straightforward. Oriented means they know where they are. This means oriented to everything. You can't be disoriented to any one piece of it. Time, place, person, situation. They need to be oriented, meaning they know where they are and they know what they're doing. If any one of those things is confused, give them confused. They're confused on one element, they're still confused, okay? Inappropriate words mean when you say, hey, do you know where you are? And they say, dog. No, do you know where you are? Fiddle. What? They don't make sense. They're inappropriate words. They're not words that go with the conversation. And incomprehensible sounds is, do you know where you are? Meh. Sir, tell me where you are today. Boo. You know, I mean, like just anything. Blah, 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 or, you know, anything. Groaning. If you can't get them to talk to you, that's their best, you know. And then none is nothing. If your patient is intubated or trached and they cannot speak, we usually still give them a none because we can't assess, but they will put a little T next to it, meaning they have a tube. So if you have a tube blocking your voice, which would be a tracheostomy or an endotracheal tube, they may, you could give them a 1, but it's qualified by the fact they have a tube in. So they'll see the Glasgow Coma scale may be reported as a, you know, an eye-opening response to pain is a 2. They had a breathing tube in, so they couldn't talk. They get a 1, so they got a 3, and then they're obeying commands. So we got 6, 7, 8, 9. We got a 9, and it would be a 9T if they had a tube in. So that kind of explains to people like, oh, well, he got discounted on his voice because he couldn't talk. We didn't know what the thing was. So you may see people, you know, their Glasgow Coma scales are lower because they have a breathing tube in, because we had to give them none for voice because they don't have a voice. We couldn't test it. So that's where a lot of people sometimes be like, but I know they're oriented, so I'm just going to give them more, but you don't. They couldn't talk to you. You couldn't assess that. You don't really know. And so technically, if they have a breathing tube or a trach, they get a 1T for their score on that range. So again, you can do the same thing if you go out to ABG Ninja. We'll go back out and show you the ABG Ninja. If you go to the main screen for the quizzes, you can do the same thing for the Glasgow Coma scale. It will tell you eyes flutter after loud sounds. What would we give it? You can have your grid in front of you because I'll give you the grid on the exam. So what is Eyes flutter after loud sounds. That would be open to voice, right? That's the only time it open, we're assuming this is the best. So if they're opening to voice, what are you giving them? 3? They are groaning only. And they push your hand away after nail bed pressure. I said, that's not the best, but let's give them the best choice. We'll give them, hey, if he pushed my hand away, then I'm going to give it localized. It's not the best assessment. But then you go ahead and do your score. And yay, you're right. So it'll give you like kind of a response. So you could kind of go through a couple of these, see if you're on the right track. If you're off by 1 or 2, mine will be very clear. I'm not going to give you nail bed pressure or anything. I will tell you exactly what they're doing, and I'd want you to put a score to it. Okay. Just making sure you know how to use that Glasgow Coma scale. And then let's see what else we have for this, and then we'll go take a little break. For spinal, we're going to talk about spinal cord injuries too, and anything we don't get to, I will finish next week. But for spinal cord injuries, for the neuro exam, I want you all cranial nerves. I want you to know the GCS and all cranial nerves. For the spinal motor assessment, you do not need to know these levels of function and the tests that go with it. I'm going to kind of put focus on the cranial nerve exam more than the spinal nerve exam. This one, I would rather you know these pieces over here. What functions does each level infer? Which functions are at each level, rather than the exam. The exam's kind of the same thing, but the important part for when we're talking about nerve or spinal is that we're going to be worrying about if we have an injury to this cord, what things are we not going to be able to do? What are we going to lose at that level of function? So I will leave that, but we break everything in spinal cord to below T6 and above T6. So those will be your key points there, is that below T6, we have certain, there's really not that much as there's just bowel, bladder, abdominal muscles, and leg muscles beneath it. We worry about above T6, because think about above T6, what's above that? Our chest muscles, our breathing muscles, our diaphragm muscles, our head and neck, we're starting to deal with higher problems and more complications. So in spinal cord, they're usually always asking what level. We're categorizing below T6 and above T6 because you have a much higher chance of complications and other problems in an above T6 injury. So that's going to be where we kind of differentiate there. And you can see right in here, right in between is where the chest muscles end and the abdominal muscles begin. That's where the seriousness of spinal cord injuries changes, is a T6 level. And then the dermatomes, I am not putting the dermatomes on the test because literally this is on every chart that you ever go and look at. And have they told you how to assess dermatomes? I'm not going to put it on the test, but it is useful. You're going to need to do it with any spinal cord patient, is where they will have you take a needle or an alcohol swab, one or the other, and you just basically are touching all the way until they either lose sensation or gain sensation back. And that will tell you, and it should match what level of injury you have in your spinal cord, right? So if you had a T8 spinal fusion, T6 to T8 spinal fusion, you can see that if you were having problems with that T6 to T8 spinal fusion, you would lose sensory somewhere below that level. So if you were having trouble with that and they're saying, I had this fusion and now I can't really feel my feet, what's going on? Well, that's where you would want to assess the dermatomes. You're looking, and when you get spinal cord injury patients, they are looking, and they will do either needle or alcohol, because sometimes alcohol, it's too subtle and people can't tell the difference. So sometimes they will do needle point pressure. Can you feel here? Can you feel here? Tell me when you can feel the needle point, and they'll make sure that you can feel it somewhere. They're like, can you feel the needle here? Okay, tell me where you feel that again. And they sometimes will go from the numb area and see where the sensation returns, or they will just start and say, where do you lose the sensation? But basically the dermatome map is available on almost any Cerner. And basically, we're just going down and we find out where sensation stops and find it on the map. And that's the level that that you will say sensation to T4, sensation to T6. But you will have a dermatome map in Cerner. And so if you have a patient that's getting spinal checks, see if your nurses are doing a dermatome assessment, because that is part of the spinal cord checks. Yes.
Nurses can do this.
Yes, it's not just for physicians. And like I said, when you're doing a dermatome check, there will be a dermatome section in the chart. And when you click on it, it will say, it will have the little picture and you can see exactly where you are, you can say, okay, I lost sensation at right above the belly button, P9. And so you can kind of correlate where their sensation stopped. That will be something that you're going to be doing for spinal cord. And we'll be looking for that because spinal cord injuries can extend throughout their swelling time. So we're going to be doing a dermatome and spinal cord assessment. But basically, you can see that there is a motor assessment. You don't have to memorize, but that will be, that there are certain exams you have them do. And I just figured that's just getting to be too much memorization. And hopefully get to the spinal cord as well, but we might have to finish up spinal cord next week. Let me pause this. So just in the interest of time, so we can get out of here and I can cover all the slides, I want to just get going. Hopefully we can do this, the rest of them in 45 minutes. So when you see all of these, so brain injury, people ask me all the time, what remit do you want on brain injury? So to answer that, I'm just going to have you guys come in a little quiet. I started the recording. So we went over and you could see there will be questions on the basic neural assessment, the GCS, cranial nerves. There will be some, the ICP, CPV questions. So we covered a lot of the anatomy, and I'm going to tell you that the neuro assessment, there will be questions on cranial nerves. There will be questions on the GCS because the assessment is everything in neuro. It really is. And so there will be assessment questions on this exam because that's our #1 intervention for neuro is a cranial assessment. The rest of it, if you are making remit guides or you're trying to consolidate your notes, I kind of put it together in that brain injuries are categorized into just straight up head injuries, bleeds, inflammatory, and disorders. So you will see there's going to be some charts with different cues, but the interventions for all the brain injury are the same, okay? And then for spinal cord injury, we are lumping our interventions into 2 different phases, acute and rehab, but brain injury, all our interventions stay the same, okay? But when you are doing your remit guides, this is why I did your PowerPoints a little bit like this, that they're already half done for you. Because, hey, you got a lot of crap on your plate. So traumatic brain head injury, these are the 3 kinds of traumatic head injuries. Now, you could have a lot of other kinds of head injuries attached to this one, but if you are going to smack your head against something or be hit in the head, these are probably the 3 things that are going to happen to you brain tissue injury wise, okay? So we're going to kind of go through the expected cues and what makes them different from each other. But as you will notice that the worsening cues, there is mostly increased intracranial pressure. The worsening cues is the fact that your pressure in your skull is getting too high. Any brain injury will cause increased intracranial pressure. I have those cues in one slide. So you can either write down those intracranial pressure cues underneath here so that you get to know them. But every single brain injury, no matter what kind it is, if it's getting worse, will show signs of increased intracranial pressure. So there will be a slide called increased intracranial pressure. I want you to use that as your worsening cues for any of these brain injuries, okay? If it says, and so this one, concussion, contusion. A concussion is your brain got zapped or hit so hard that it had a moment where it reset all its electrical activity. All its electrical activity stopped, meaning there were no thoughts for a few seconds, and then everything kind of got going again. So it causes a transient lack of consciousness or confusion because you got knocked so hard that everything stopped in your head for a few seconds. And that is almost like being like hitting the chest real hard and your heart going, whoop, stopping for a second and restarting. The brain can get hit real hard. And if you have a loss of consciousness, it could mean that you have a concussion or a contusion. A concussion means that you have electrical activity stopping, but no damage to your brain tissue. If they do a CT scan or an X-ray, a concussion will show nothing. No findings on a CT scan or an MRI because no damage happened to the brain. The damage was the electrical activity got stopped for a minute, but then it all restarted again. So it was just a jarring. Concussions do not leave any brain injury behind, but there is a risk that there was a brain injury. A brain injury is called a contusion. That is a bruise on the brain. So they go together. You can have contusions with concussions. You can have concussions with contusions. So if they've done your CT scan and they said, there's nothing, you just got your bell rung real hard, they'll send you home with a concussion. If they do the CT scan and they see a little bit of a blood collection or just literally what it would look like to have a bruise, then that's called a contusion. You don't usually, you can have contusions without concussions. You can have concussions without contusions. Concussion just means that you had a little bit of a loss of consciousness because your brain activity stopped for however long. The amount of time you were knocked out was the amount of time that your brain went, I don't think right now. It just got bam. And all those neurotransmitters got shook up and all those electrical activity got stopped and everything had to find its home and restart again. Okay, so a brief loss of consciousness means you've had a concussion. That does not tell you whether you have a contusion or not. You need to look inside the brain at a CT scan to find out if you had a contusion or not. A lot of times they don't want to, if they didn't do the CT or they just tell you you had a concussion, we're going to put you on concussion protocols or things. They're assuming you have a contusion with it. If you got hit hard enough to lose your electrical conduction, you probably have a little bruise left behind somewhere. It's, not that surprising. So what we expect if you've gotten your bell rung hard enough is you're going to have a headache. Okay, that's all that neurotransmitter reset, kind of giving you some frustration, some swelling in the brain while it's all trying to recirculate, but it's transient. It will go away. A contusion itself is a little bursted capillary. There's a little bit of blood on your brain. It just looks like a bruise. It would be a little spot. And it will cause a little bit of localized swelling. The brain tissue itself, so our brain in there, does not like to touch the blood. It's squeamish. It would like the blood to travel alongside it, but it doesn't want blood in the actual neurotransmitting area. You know, where the little, I don't know if you went over the neuron in block 3 when you talked about the little, they don't touch each other, those neurons. They just kind of hang out next to each other and they use neurotransmitters and electricity to transmit. Well, if you got your bell rung and that sort of area just kind of has a little bit of a bruise in it, well, the tissue right there, you don't want blood where you're supposed to be exchanging neurotransmitters. That should be clear. It doesn't mind the blood in vessels around it because then it could pull out what it needs, but it doesn't like blood in the tissue. Blood in the tissue gets in the way of neurotransmitters and it actually causes some swelling of the tissue itself. So whenever blood is loose of a blood vessel, whether it be a bruise or a full-on bleed, it's going to cause swelling around that area where blood is touching the tissue. Because when blood gets into brain tissue, now we've got red blood cells in neurotransmitter spaces. We've got fluid in neurotransmitter spaces. It doesn't work real well in that area, but it's a small little bruise. So it's not going to affect our whole workload. It's just a tiny bruise. Maybe you got smacked with a baseball bat and you have a bruise there. Okay, you got hit with a softball or a baseball and you have a little bruise in your frontal lobe. Maybe you're a little more irritable. But that's about it. That the neurotransmitter in your frontal lobe that's involved in managing your emotions and your reactions and your personality maybe has a little bit of a bruise in it and isn't functioning at the top speed. So you will kind of have a headache. You will have these localized changes and people are like, what does that mean? What do you want me to write down in my notes? And I'm like, It just means wherever your brain was injured is what symptoms you're going to see. So if someone got rung real good on the side, they may have trouble word forming. Those are the localized changes we're talking about. I'd love to give you this contusion gives you this neuro assessment. Localized changes based on how bad the bleed was, what the swelling is, but most people with contusions do not have any visible side effects other than the headache because they have a brain injury. Photophobia, nausea, vomiting. What does that mean? Their sensitivity to light and they have nausea, vomiting. That's just nausea, vomiting is a non-specific cue that your body knows there's something wrong with it and it's trying to get rid of something toxic. Well, if the brain is swollen and has some blood in it, it knows there's something wrong and it may send signals around like there's something toxic in my body. Well, it's its own blood that it bled into its brain and it's causing an inflammation response in the brain. The brain gets a little bit hinky about any inflammation spots into the brain and it's like something's wrong, and sends off warning signals to the body. So you will get this generalized nausea, vomiting. That's very common with any head injury. And that's just your brain saying something's toxic up here. It's bleeding on itself. It doesn't know, but it will give you a little bit of nausea, vomiting. Difficulty, the photophobia is just that there's a lot of input and it's having trouble processing right now. So that's pretty common with most head injuries is headache, photophobia, nausea, vomiting. So you're going to see that. That's not really non-specific. It just means your head has some kind of damage to it. Worsening, though, would be if a contusion, a bruise, didn't stop bleeding, right? I expect it to be localized, small. They may have had a loss of consciousness, but they come back. If they don't come back with their loss of consciousness, you can't call it a concussion contusion. A concussion contusion means they had a brief loss of consciousness, but they regained it. We just find out how long they were out of it and how bad that will kind of correlate to how bad the contusion might be. The longer you lost consciousness, probably the longer your brain was in trouble. And so the greater the size of the contusion. If you blacked out for like 3 seconds and came back, they're not too worried about a strong contusion. The longer you've lost consciousness usually correlates to a longer or a worse contusion in the brain. But whenever you have a contusion, or if you've been outpatient or you've taken care of someone that had a concussion or contusion, how do they go home? They get to go home, but what do you have to do for a concussion contusion patient? You have to watch them for the next 24 hours. Somebody responsible has to watch them, because how do we know if that little bruise turns into a bigger bleed, that it never stops bleeding? We won't know unless someone's doing a neuro assessment. So, hey, we send people home with unqualified people to do neuro assessments all the time. You're way more qualified than them already. So, hey, if we send neuro patients home to be assessed by their parents or their spouses or their coworkers, you can do this, right? And how do you assess someone after they go home after concussion? Maybe you've seen it on TV, maybe you've done it. What do you do for them? Don't let them fall asleep. Keep them awake. Why do they say that? Well, yeah, because we're sending you home with an unqualified person to do a neuro assessment. Well, the worst kind of neuro assessment is when you don't wake up. So basically, your GCS went to 15 to 13. All a layperson is going to know is they didn't get, so they say keep them awake, because if they fall asleep and you can't get them up, we're way far along. So they say keep them awake, and the other reason we're supposed to keep them awake is so we can get a full neuro assessment. You'll notice if the patient starts getting confused, or if the patient starts, like dropping things from their right hand because they can't control their right hand anymore. We're looking for any changes from baseline. So yeah, that's what they're looking for, is worsening cues. The contusion will heal, the concussion regenerates itself, but we need to make sure that contusion doesn't become a full-on bleed. And so we are watching their neuro status to see if there are any changes, and we'll let lay people do it, because if they're told, hey, if you can't wake the person up, call 911, because that's a sign that their brain's getting worse. And that's why they get those distractions. We'll be doing a little bit clearer assessments. The other thing that can happen is that you can have a skull fracture. We only really worry about a basilar skull fracture. You can have skull fracture anywhere in your head. Skull fractures will go along with contusions, because there's no way you can be hit hard enough to break the bone in your skull and not have a bruise underneath it on your brain. Okay, so if you have a skull fracture, you probably have a contusion or a concussion or both underneath it as well. So I'm not saying that skull fractures, this is the only kind of skull fracture. I'm saying it's the only kind of skull fracture that has specific signs and symptoms that go with it. The basilar skull fracture, what does basilar mean? Base, means the base. So it means the base of the skull is broken. If you fracture the top parts of your skull, basically they're just looking underneath the fracture for a contusion. But if you fracture your skull, we're really just looking for contusion and localized signs and symptoms. But a basilar skull fracture is a little different. Basilar skull fracture means you broke the bottom part of your skull. So if you broke the bottom part of your skull, what's right underneath the bottom part of your skull holding up your brain? You got a lot of ventricles hanging out right at the bottom of your skull, because that's where we put all the cushion to hold up your brain, is right underneath. Those ventricles are sitting right underneath there. And so if you break the bone underneath, you have a very high risk of having ripped the ventricle and the CSF leaking out. So with a basilar skull fracture, you will see specific things. And I think I got my one win in clinical with, I don't remember who was it. Who was the patient that had bilateral orbital edema? Yay. Yeah, Jessica came up and she was like, yeah, they got into some kind of fight. We don't know what happened to him, but he must have gotten hit in both eyes. And I was like, dang, that's a sign of a basilar skull fracture. Because if you have bilateral periorbital edema, which means that you have bilateral black eyes, that is one of the signs of a basilar skull fracture. So luckily you got to get back into the chart. And what did you find in the chart? In the CT scan, it showed the basilar skull fracture. So there is a chance that maybe your patient got hit in both eyes, but that's pretty rare. This is a sign of basically that bottom of the brain there where it stops. At the very base of your brain, you are draining blood and CSF, and it's going to collect in your sinuses right here. And so this, what we call raccoon eyes, is the bilateral periorbital edema. You could get it if you got your nose broken real hard too, but it is a sign to go look at the CT scan for your patient to see if they had a basilar skull fracture. And the reason we care more about a basilar skull fracture than any other is that this one's at a high risk of a CSF leak. So there are a few things, and what we are looking for, so if you see this, or you see bruising behind your ear, I forgot to ask if your patient had bruising behind their ears as well, but that's the two places that if you are bleeding out of your skull from the bottom, it will collect in your sinuses, so it will show up in the eyes and behind your ears. If you have a patient that had a head injury and has periorbital ecchymosis bilateral or some bruising behind their ear, it's a high risk of a basilar skull fracture. And the reason we really care about it is because of the CSF leak that we can have. If you have any CSF leak, it's going to show up as clear drainage from your nose or clear drainage from your ears, because where's the CSF going to get out? It's going to be in your sinus cavity, but where do your sinus cavities leak from? Your nose. And if it's up here and collecting behind your ear, it may get into the eustachian tubes and come out your ear. So if you see, you would be on the lookout with a basilar skull fracture. So once you know your patient has a basilar skull fracture, be on the lookout to see if they have a CSF leak. They may or may not, but it's a high probability that if we broke that bone under there with enough force, that we might have broken the ventricle and be leaking some CSF out as well. So the reason we're asking, if I tell you have a patient with periorbital edema and Battelstein, and they start having drainage from their nose, what do you think it is? A CSF leak. So just be on the lookout. How do we test for a CSF leak? Well, we said CSF has a lot of glucose in it. It's glucose high. So you can test it for glucose. You can send some off to the lab and have a glucose test done on it. Or you can put a little piece of gauze or tissue under the nose and it will halo. And that's a picture of what it halos. Halo means that this was the drainage, and then it will halo out. And then do you see this on the outside? CSF will have that double ring. It will have an extra ring on the outside because the glucose travels a little bit further, and it will have an outer ring. So if you put it on a tissue and it was not CSF, it would stop kind of right here, and that would be the end of your blot. But if it's CSF, it will have a second halo on the outside. So it's called a halo sign because it literally is an extra, it's like a double rainbow. If you put that stuff on a tissue or a gauze, you will see that double halo, and that means it's CSF. And what would we do for a patient that has a leaking CSF? What do you think you would be worried about for leaking CSF? I would be worried about the pressure, that basically by having a headache, they're leaking CSF because, if you don't have your cushion, your brain's going to feel a little poor. But what's the other problem? You have a crack in your skull that is open and leaking CSF, which is full of sugar. Infection, 100% infection is something we do not want with this. It's something we don't want with any brain infection, but this is basically like a compound fracture, an open fracture. There is an opening from your sinuses, which are foul and dirty and disgusting, to our head. High risk of infection. So that's why we would want to know if we see that CSF, we're at a high risk of a brain infection. And that's why the worsening cues for this is a brain infection, because you are at a higher risk of an infection. Of course, you're at risk of any head injury is at increased risk of intracranial pressure going up. But that's why the specific risk of infection is higher here. We have a broken bone and an open ventricle with plenty of sugar dripping around. Great place for those sinus bugs to get up in there and make a home. So that's why the worsening cue there. With the concussion contusion, we are worried about a worsening bleed because it's a bruise. And if they're on warfarin or something, a contusion could turn into something a lot bigger. Can a patient have a basilar skull fracture and a contusion? Heck yeah. So now you're at risk for both an infection and a bleed. So we will be needing to monitor that. But I just wanted to point out those different things. With other skull fractures, we are still worried about infection as well to the brain, but because the CSF is not as involved with regular other fractures, we don't include it as much. The basilar skull fracture is the one we really worry about, a CSF leak. The diffuse axonal injury. So your patient didn't have a brief loss of consciousness, they're staying unconscious. You got them, you've never gotten a response from this patient since their injury. A diffuse axonal injury, basically, you don't have to diagnose any of these. These are just all the different kinds and how you recognize them. But basically, a diffuse axonal injury, the patient never woke up. And the reason the patient never woke up is because if the brain is thrown, and this is usually high speed, high injury. So car accidents, motorcycle accidents, high speed accidents, boating accidents. If your brain gets thrown front and back and goes around, like those neurons actually will shear and twist because of that brain bopping back and forth in the head. Even though it has CSF as a cushion, if it's high enough speed, it can actually literally twist your neurons and break your neurons. And if you diffusely break and twist and break all the neurons in your head, your brain will no longer be functional. So a lot of patients, we will monitor them. If they never woke up and their Glasgow coma scale has been low since the accident, there is a very high chance that they just didn't have a big old contusion. They've got a diffuse axonal injury. So these are the patients that never really wake up. And you can imagine if we've sheared and broken every neuron in your head, what's the inflammatory response on that? Oh, it's huge. Which means not only are you not functioning because your neurons broke, but you're not functioning because the inflammatory response to your brain causes a ridiculous amount of swelling. So you might have seen some of these in your ICU experience, but these are really the three kinds and what they do. If you had a head injury, you either have a concussion contusion, maybe it's little contusions, maybe they're big contusions. You might have a skull fracture, which we're at risk for infection. And if it was severe enough and high speed enough, if they never woke up, it might be a diffuse axonal injury. The bleeds, again, you can have bleeds with skull fractures. You can have bleeds with injury. You can have bleeds just because vessels ruptured. This just means you've had a bleed in the head. I don't know what kind. You would have to take a look at your patient and see why they're having a bleed. But I will tell you that the differences are epidural hematomas are usually arterial and they're usually fast onset. So epidurals, this will come, so patients will get epidural hemorrhages after traumas. They may get epidural hemorrhages from blowing a blood vessel, if your blood pressure is high enough. If you blow an arterial blood vessel, you can get epidural. But it's basically you broke an artery in your brain, and it is a fast bleed because the subdural space houses the arteries, most of them. And because this bleed is happening so fast, it's pumping out with each beat, this bleed rapidly displaces brain tissue. Because all of a sudden now, where brain tissue used to be, we have arterial pumping, right? You are getting a large amount of blood, and that has to push something out of the way quickly. And so this causes an abrupt or quick loss of consciousness. These are the patients like that are out skiing, hit a tree, and they're like, I'm fine. I think I stopped my bell wrong. I'm okay. I think I'll be okay. And 5 minutes later, they're not okay. We actually saw this in clinical one day. We had a patient come into the ER. She had the worst headache of her entire life. She was playing cards with her friends, and she had a massive headache. She's like, oh my God, I can't even think straight. My headache, my head hurts so bad. And she came into the ER. She lost consciousness in the ambulance on the way in. And when they did her CT scan, all you could see was white. The whole one side of her CT of her brain was white with blood, and the brain had been pushed all the way over to the other side. This bleed had happened so quickly, and she had an aneurysm that blew. And that was the worst headache of her entire life, was when she could feel that blood just starting to compress her brain, but she lost consciousness quickly afterwards. Epidural bleeds happen fast. She was talking when EMS got to her. She was intubated and non-responsive by the time she got to the hospital. So it's like 10 minutes. So it just happens real fast and very quickly. Like you go from conscious to nothing. And that's because the blood is coming at such a rapid rate. It's compressing the brain fast before it has a chance to compensate, pushes out of the buoy very quickly. So one of the cues of it is a severe incontinence, because it's happening very fast. It is causing a great amount of pressure in your head, a great amount of headache, and they will have unilateral changes. If you're going to see something that looks like a stroke, a lot of strokes are bleeds. But if it is happening from one side of the brain, it will push the brain to the other side. You will lose function of that one side of the brain. You may lose function of the entire thing, but when it first appears, and that will be your expected, like there isn't a lot we expect with an arterial bleed, except that we identify it happened fast. Usually we don't even know it was an arterial bleed until they lost consciousness. But that's what we expect to see with an arterial bleed, is that it's severe, it's painful, it happens quickly. You will have those unilateral changes, and then they will lose consciousness quickly. Quickly, and pretty fast. No compensation for the brain. Subdurals, though, are venous bleeds. Subdurals are usually slower. They are venous bleeds. And so you get a slower decline in your neurological exam over a couple of days. This is someone that was probably fine. And let's just say I fell and tripped in the bathtub and knocked my head real hard and ended up with a subdural. I don't know that. I just said, yeah, I never lost consciousness. I'm just going to kind of watch myself at home. But then my husband notices that I'm getting more forgetful, and that maybe I'm starting to, he's like, you're kind of dragging a foot, and maybe you're just starting to, just kind of get a little weak. You're leaning to one side. You're starting to get that droop. And they're like, is everything okay? And you're like, I'm just not feeling that great. And subdurals happen slower. And the worst part about it is that little old people, as you get older, your brain shrinks. This is like a real thing. It shrinks about like 10%. So that means that when your brain filled your head when you were young and strong, now you're older. And so the brain's kind of compressed a little bit, which kind of stretches the blood vessels between the dura and your brain. As your brain shrinks a little bit, it kind of shrinks those blood vessels a little bit. It makes them more prone to bursting. So poor little old people are already at higher risk from having kind of a little shrunken brain, but then that also means they've got room to bleed into. So little old people with their shrunken brains can take a little bit of blood. So some little old people on Coumadin at home, they fall, they hit their head on the tub, and they're like, I'm fine, I don't need to call anybody. I'm just feeling a little dizzy, a little nauseous, but I'm okay, I'll just sit down. And they sit there, and they sit like that for a couple of days, and then they slowly get worse and worse, because this This is an ooze. And it's slowly oozing. And so they can happen to have a day or two before it starts causing pressure on the brain. With a younger person, it may start causing pressure on the brain sooner. Some venous bleeds are faster than others, but subdurals usually happen slower, and you start seeing neuro changes. That's when people are like, you know, grandma was fine, but grandma started getting loopier and loopier after she's been hitting her head on the toilet, and now she doesn't know where she is. And so that would probably be the picture of a subdural. They have a dull, throbbing, constant headache because they are getting blood on their brain. Blood on the brain causes pain. It will stimulate those nerves. The brain does not like having blood in it. It wants the blood in the vessels where it belongs. It does not want blood in its tissues. It will hurt as soon as blood hits its tissues. So this is a dull aching though, because it's a slow ooze that's slowly growing pressure in the brain. So they have all the same things. They're just slower on onset. But when you go and take your CT scan, it'll tell you whether it's an epidural or subdural. So this is just nice to know, probably stuff that I'll be giving you in your tests. You know, if grandma came in and has a slow declining neurostatus over a couple of days, I want you to suspect subdural. If I have someone that was just in a car accident, was talking to you and lost consciousness, probably an epidural. And then an intraparenchymal, you may see these. These are bleeds inside the brain, not on the top. They could be anything. They're capillaries usually, because capillaries are inside our brain. So my mother-in-law had an intraparenchymal hemorrhage in her cerebellum because she has high blood pressure and didn't take her meds. And it was my sister-in-law's wedding, and she was stressed and running around. The night after the wedding, she had a stroke. And her only sign and symptom of this stroke was that she could not stand up, and she was so dizzy and nauseous. She crawled to the phone because she could not stand up. And anytime she stood up, she was dizzy, she was nauseous, she was throwing up, and she couldn't stand up. Every time she tried to stand up, she would fall down. And so she crawled to the phone, called 9. She's like, I knew something was wrong. And it was in her cerebellum, which if you look back at cerebellum, what does the cerebellum do? Balance, coordination, proprioception. She couldn't do any of it because that's where her bleed was. And so that was where she blew a capillary in her cerebellum and had an intraparenchymal. What do you notice about these two bleeds right here? They're at the top of your brain, right? You can go and get them. The epidural and subdural, they may be able to go in there and evacuate those bleeds off the brain to stop the swelling process, stop the bleeding process. Intraparenchymals, you can't do anything about. They have to stop bleeding and resolve on their own, because we're not going to bore a needle through your skull, through brain tissue to try and pull blood out of brain tissue. They're not going to do anything about it. Intraparenchymals, no matter how bad or how good they are, or small or big, they have to heal on their own. And there really isn't much we can do about it, but the signs and symptoms will be very similar. Not much you can do. They're found on, they're named when you get the CT scan and they see where they are. But both of these, what are we worried about with an aneurysm? Bleeding. It's just going to turn into, I mean, if you have an aneurysm, again, it's going to be like a coronary or an abdominal aortic aneurysm. What do they need to do? They're going to need to keep their blood pressure low. But really, when we're recognizing cues, an aneurysm is usually found incidentally because there's not a room in the brain. Any swelling of a blood vessel in your brain can cause pressure and pain right where it's causing. So they might just come in with frequent headaches. And they give them all the migraine treatments. And they're like, I don't know, nothing's helping. They finally get a CT scan and they can see the aneurysm on the CT scan. They will watch it. They will only intervene on it if it gets large and causing more symptoms, just like we don't intervene on an aortic aneurysm unless it's large and causing, you know, dissecting. And with an aneurysm, we usually don't do it unless there's changes in the neuro exam. It's getting large enough to start causing pressure on the brain, or if it bleeds. They will, now there is a lot more general, they used to have to go in and do brain surgery to put them in. Now they have interventional radiology where they can put coils into these aneurysms. They can do all kinds of things with them. So you will see in the intervention section, there are some specific interventions for aneurysms, but usually it's keeping your blood pressure down, just like cardiac aneurysms. Brain aneurysms are the same way. And tumors, they're just going to cause changing because there's just brain tissue growing that's growing out of control, getting bigger and bigger, and that's causing an imbalance in the pressure process here. So I've introduced you to the symptoms. let's talk about what we do. Here's the worsening cue for anything. This is what increased ICP looks like. These are the cues of increased ICP. Basically, any decline in your neurostatus, any decline in your GCS or your neuroassessment could be a cue of increasing pressure in your head. So that's why they're always asking, what was the patient like baseline? What were they like when they came in? What were they like before? Because we are looking for changes, because changes in your neurostatus mean that there's something going on in your head. Just like you're listening for lung sounds for fluid and stuff, we are looking at the brain. The only way to see how the brain is doing is by doing a neuroassessment. So unfortunately, if you hate assessing, don't go into neuro. Just don't. Because everything, all the interventions, all the things are based off of your neuroassessment. So when you call the doctor with a declining neuroassessment, you're going to CT scan. It's just your assessment is everything. And your assessment is the first cue to worsening problems. So the other things that we can see, though, is if your brain injury is getting worse, they may see that you are shifting or losing ventricle space. So if your brain is swelling, let's say you had a contusion or you had a tumor or whatever, this patient, what do you think happened to this patient here? This is a normal CT. And then we have afterwards. What do you think this is here? What do we see on X-ray that's shiny? So yeah, we are seeing something new here. That would be blood. This is a new bleed. So this is the patient before, and you see how there's a line of symmetry right down the middle. And we have these beautiful little butterflies off to the side. This is your ventricles. They should be symmetrical. There's a line of symmetry down the side. So when they're looking at these CT scans, the first thing they're looking for is a shift in symmetry. A shift in symmetry is a sign that there is swelling, either blood or tissue or something is swelling and pushing your brain out of the way. Just like a pneumothorax, we're listening, we're looking for it to be causing symptoms of the heart and lungs being pushed out of the way. Here we're pushing brain out of the way, so you're going to see a decline in your neurologic assessment. You may see a midline shift, you may not. You may have seizures. Remember, anytime, just like with cardiac, whenever your cardiac muscles are swollen or your electrolytes off, you can have dysrhythmias. A seizure is a dysrhythmia of the brain, where those connections, those neurotransmitters are not completing conduction. So if you're having a swollen or you're having blood or an irritant on your brain, something's going to happen to the conduction in that area, or an increased risk of seizures. So if your patient never had a seizure in their life and now they're having seizures, that's a sign of increasing intracranial pressure. If your patient only had one seizure every 6 months and now they're having 2 or 3 in a shift, that's a worsening cue as well. So decrease in your thing, a midline shift if you get a head CT, new onset of seizures or seizures we can't control. If they put in a CT, it's increased intracranial pressure. Hey, if you have a number that says high, then you know you have increased intracranial pressure. But we don't generally put those invasive things in until the last resort. And so a lot of it, we just have to guess from your assessment, from seizure qualities, from changes in what they're doing. Late. So late. This means that not only do you have pressure in your head and increased intracranial pressure, now we have pressure on your brain stem, which means that swelling is about to push out the hole. The brain stem is the only thing coming down to that spinal cord hole. If we start putting pressure on the brain stem, that means that brain is being pushed down to the point that the pressure is now almost extruding out of there. That will give you this thing called Cushing's Triad. It's not related to Cushing's disease at all. It just happened to be the same doctor. So he got to name everything. But Cushing's Triad is increased blood pressure, decreased heart rate, and decreased respiratory rate. You'll have to just memorize that. They are the opposite of shock. The opposite of shock. Because isn't shock a decreased blood pressure, increased heart rate, increased respiratory rate? This is something you don't expect your body to be doing. This doesn't make any sense at all. And it's because your brain stem is not controlling your bodily functions the way it should.
Your vital signs are in the brainstem, right? That's
correct. And so when we start pushing pressure on the brainstem, you're finding things you don't expect. The brainstem's not working properly. When the body's in trouble, it usually has shock-like symptoms. But here, this is like completely the opposite. It's your blood pressure's going up, your heart rate and your respiratory rate are going down. That makes no sense because it doesn't make sense. Your brainstem's dysfunctional. So Cushing's triad is seen as a late sign. You don't want to wait till your patient shows you these signs. You're almost already got too much pressure in your head. You would see a decrease in your neuro assessment or possibly some seizures, or if you're monitoring, you would see that pressure rise.
I do have a little slide here on what herniation looks like, and this is the blown up of that picture. This is where the brain is actually herniating into the spinal cord, and you can see here that the more brain that herniates, the more compression you're going to get of these two vital arteries here. And if those two vital arteries get cut off, and you end up with brain tissue all here, then we have cut off blood flow to the brain, and that is considered actual death. If the brain cells die after 15 minutes of no oxygen, just like your heart will die and stop pumping, your brain will stop managing bodily functions. And so that is considered brain death, is full herniation to the point where there is no blood flow to the brain. And I don't mean not a little dribble, I mean none. So you can see on this angiogram here, this is normal blood flow here. This is the circle of Willis, and this is everything headed off to around the brain. And here is the circle of Willis, and nothing. Nothing after that. Complete emptiness of blood flow around the brain, and that is significant because this brain has been anoxic. Anoxic brain tissue will lyse and swell, and it will not get better. If someone has been declared brain dead by cerebral angiogram or apnea or anything that basically is saying we have no longer any functions of our brain stem and our brain, if you're declared brain dead, it is considered dead, just as good as cardiac dead. So I do have a slide there on brain death, which is hopefully something that we will prevent by doing our interventions. But if a patient does herniate into the spinal cord and that is not fixed within 15 minutes, they can proceed on to brain death. Brain death is defined by every hospital has a confirmatory test for brain death. It varies between hospitals, but usually the confirmatory test is going to a cerebral angiogram and seeing no blood flow. If you are completely apneic, if they take you off the ventilator and there is no respiratory function whatsoever, that is also considered brain death. There's a couple of different, you'll have to read your hospital's policy and procedure on declaring brain death. Every hospital has one, and they will follow that procedure to declare someone brain dead. Cardiac dead is very easy to declare. There's no more heartbeat. Brain death, you want to be sure that the swelling has caused irreversible and brain damage. So the patient is declared legally dead if they go through the brain death process. Even though the heart may be beating and the ventilator is providing oxygen, this legal death means that if we removed any artificial means of support, you would die naturally. Because the only thing providing you with any ventilation and any oxygenation to the rest of the body is the ventilator. So if you are declared brain dead, you are legally considered as dead as if you're cardiac dead, and the only reason that you can prolong ventilator support is for organ donation. You're also not supposed to ask families for organ donation. There's a lot of controversy amongst families that people do believe that the hospital staff are not taking best care of their loved ones in order to harvest organs. And so they do believe that, if the hospital staff approaches them about organ donation, it's because hospital staff had something to do with wanting the organs. And so they remove hospital staff from the discussion of organ donation. So it's done by a third party, which is the organ procurement organization and here for Arizona, it's Donor Network of Arizona. You call them when they have referral criteria, and they take that discussion out of your hands. You don't need to worry about it. If the family brings up organ donation, or if they meet the criteria that basically their GCS is less than 5, they're already on a mechanical ventilator, and they've lost 2 or more of their brainstem reflexes, or if you feel that the patient would be a good organ donor, or if you want to discuss it with somebody, you could call Donor Network at any time, and they will discuss whether the patient meets criteria, doesn't meet criteria, and if they do meet criteria and want to have a discussion with organ donation, they assist the hospital in going through their brain death policy, and they assist with talking to the family. So you don't have to take that on your own head. In fact, you're discouraged from doing so because they want to remove the hospitals. Hospitals are providing best care to these neuro patients that could be reaching brain death, but they want to remove the stigma of hospitals doing something to someone to get organs. That's not something that hospitals do, but it's still a myth out there, and so we want to remove that, and we let a third party take care of organ donation conversations. Does anyone have any questions on that? I'm probably not going to test on it, but it's something that a lot of people want to talk about or discuss. So I do put it in here that the only way to become brain dead is to herniate into your spinal cord and cut off blood flow to your brain. And the brain swells to the point that it cannot even do its autonomic functions. Autonomic functions meaning breathing, heart rate, temperature control. If the brain cannot function itself and do any autonomic functions, then you are brain dead. This does not mean persistent vegetative state, where if they remove the ventilator or decrease the ventilator support, the patient still breathes on its own. If the patient's breathing on their own, has a cough, has a gag, does anything, I mean, that may not be that they ever mentate again, but they are not brain dead. You have to have an absence of respirations and no brain function at all to be considered brain dead. Does that make sense? So that's that. Please feel free, any questions, let me know if you have any questions or concerns about that. So we finished our cues. We're looking into the key assessments. Again, the key assessments on any neuro patient with any consideration of neuro damage is the cranial nerve exam and the basic neuro exam. We're going to keep watching those exams for any kind of worsening. If you're concerned about increased intracranial pressure, we'll be observing for Cushing's Triad. So you're going to look at the blood pressure, heart rate, respiration. If you see your blood pressure trending up and your heart rate trending down, your respiratory rate trending down, that could be a sign of Cushing's Triad, which means you have increased intracranial pressure. And we will also keep an eye on our mean arterial pressure to ensure that the mean arterial pressure is greater than 60. And if we are seeing Cushing's Triad with it, we're probably going to want that mean arterial pressure to be even 70 or 80 to overcome whatever intracranial pressure we are having. We can monitor intracranial pressure, but again, it's highly invasive, and they will probably only do it if you are having a worsening cranial nerve exam or neuro exam. You'd have to have a pretty big neuro injury to get invasive ICP monitoring, because it is something that they put into the brain. You don't want to do that lightly. We can usually watch the increased intracranial pressure by the neuro exam. So again, not good news if you don't like neuro exams. Don't be a neuro nurse, because they're really relying on you. So we're going to do the interventions, and this is for all cranial disorders. So I don't care if it's a bleed, if it's a basilar skull fracture, if it's a tumor. These interventions will work for any neuro exam, okay? And these are our base interventions for any cranial nerve deficit, no matter what kind it is. We're going to continue to monitor that neuro assessment. That's the number one intervention, is frequent neuro assessment. The second one is maintain oxygenation to the brain. If the brain has had any injury, swelling, damage to it whatsoever, we're going to make sure that they have good oxygen. This may be that your oxygen saturation may be 92%. We're going to go ahead and just bump it up anyway. The brain eats 20% of our total oxygen. It's a high consumer of oxygen, and we want to provide it with the best oxygen. So a lot of neuro patients are on oxygen, just like most cardiac patients are on oxygen. Why not? Let's give oxygen for healing. There's a very low threshold for starting an oxygen on a neuro patient. Go ahead and start oxygen. We want it going. We want to prevent any ischemia to the brain. keeping pulmonary hygiene going, avoiding atelectasis pneumonia. We don't want respiratory infections. They all compromise our oxygenation, and we need all the oxygen going up to the brain that we can. Maintain perfusion. Keep that mean arterial pressure. Again, we want it, that mean arterial pressure of 60 means that you don't have any intracranial pressure. We're assuming that a patient with a cranial swelling of some kind has some kind of elevated intracranial pressure. It may be 8, it may be 12, it may be 15, we may not know. So keeping that mean arterial pressure up above 70 is a goal for most neuro patients. We want that cerebral perfusion pressure greater than 60, and unless we have an ICP monitor, we don't know exactly what our intracranial pressure is. So we just assume that it is high, and we want to maintain a mean arterial pressure that will provide perfusion even if our intracranial pressure is high. So remember, a mean arterial pressure of 80 will provide perfusion even if your ICP is in the danger zone. So a higher MAP is usually requested. We don't want it going above 100. 100 is very high and could cause cerebral blood vessel explosions, which is not going to help our bleed or our status epilepticus or our inflammatory thing. We want to keep our mean arterial pressure really in that range so that we're providing good blood flow, but not too much. Okay. One of the good ways to maintain cerebral perfusion is maintaining your neck in the neutral position, meaning right upright, not bent to the right, not bent to the left. If we bend our neck to the right or the left, or put your chin to your chest, then we are decreasing, basically flow of the carotids or the jugular veins. We're decreasing flow up to the brain, and we're decreasing flow out of the brain if we have our neck off to one side or chin to chest. So you want to maintain your neck in neutral position, almost like it has a C-collar on it, and that's to provide your carotid arteries no restriction. Does that make sense? So make sure your neck is in neutral position, not because they have an injury in their neck, but because we want those blood flow unrestricted. Maintain cerebral perfusion, keep your MAP up, and keep your neck straight. Neuro patients always have their neck flopped to one side, so you always see people have pillows and towels and things rolled up and stuffed up next to the neck to keep the neck in that neutral position so we don't restrict blood flow. Of course, we're going to want to decrease the intracranial pressure. And how do we do that? We do that in numerous ways. So this is important. Could you put a C-collar on as prevention? They could probably maybe do a soft C-collar if they want one. But again, you don't want someone tightening the C-collar too much and putting, pressure on the arteries or veins that way either. So a soft collar, possibly, but generally we usually support with pillows or rolled up towels on either side of the head, just to keep that neck from flopping forward or to the side. You don't need to go as invasive as a C-collar. Those are usually pretty uncomfortable. But maybe a soft one, if you're really having trouble, that could be an intervention you could ask for. But just make sure you don't tighten it too much around the neck. No, not usually C-collars, but you can. So the main interventions are decreasing intracranial pressure. So again, keeping the neck in neutral position helps venous drainage, helps keep blood out of the brain, keeps blood draining from the brain, keeping the head of the bed elevated greater than 30 degrees at all time. I don't see any neuro patients that are laying flat unless they have a lumbar puncture or a lumbar drain. Otherwise, head of the bed up. Does that make sense? Remember, we said you want to lay flat after a lumbar puncture because we're draining fluid out of the lumbar space, and that's going to cause a headache to sit upright. The only exclusion to this, so I'm going to write that there, only exclusion to the head of the bed being up is lumbar puncture or lumbar drain. If we are actively pulling CSF out of the lumbar space, then that is when you would lay flat. Okay, the only exclusion to that, decreasing intracranial pressure, we are pulling CSF out, And so we've decreased the pressure. You could lay flat during the recovery time. If you're having a lumbar drain where they're constantly pulling CSF, then you may lay flat. Does that make sense? So head of the bed upright greater than 30 degrees to get venous drainage from the brain, but you can lay flat if they have, they're recovering from a lumbar puncture, or if they have a lumbar drain in that is draining CSF. Okay? Otherwise, head of the bed up, neuro patients are sitting upright, unless they've been poked in the, for a lumbar drain. If that is not enough, and you're seeing neuro changes, and you're having a worsening GCS, and you're having worsening neuro exam, then we are having an increased ICP because you're showing your worsening cues, a worsening exam. Maybe your Cushing's triad is getting more, your hypertension, your high blood pressure is going up, your heart rate's going down. Maybe, so your Cushing's triad's getting excessive, your cranial nerve exam is worsening, and the GCS is going down. Then we're going to need to get more aggressive. The next, so least invasive, sitting them upright, neck in neutral position. Then we'll go to an osmotic diuretic. Those are things like mannitol. Mannitol is a special diuretic just for the brain. They can give mannitol anytime. It is a diuretic, but it is a super diuretic. And what it's going to do is you're going to pee a ton, and we actually are physically dehydrating the brain tissue. And normally that's not a good thing. I'm not saying it's not going to cause problems on the brain, but the brain tissue is so swollen, we want to get the fluid out of the brain. And that's what mannitol and hypertonic saline do, is they pull fluid out of the tissues, and mannitol, you will pee it out. Hypertonic saline, you'll beef up your circulation, but you will pull it from the tissues. Mannitol is the primary one. I don't see hypertonic saline too often on neuro patients, but if it is combined with a low sodium, they will use hypertonic saline. But mannitol is really your key intervention to dehydrate the brain. You will see patients with brain swelling on mannitol, PRN, for increased ICP or for worsening exams. Sometimes they're on it every 6 hours or so. Yes, you will become massively dehydrated, but that's what we're doing to save space in the brain, because remember, we are trying to avoid herniation. If the brain tissue continues to swell and we're getting close to herniation, then it would be better to dehydrate that brain and shrink it than it would be to kill it. So mannitol is something they will do to dehydrate the brain and shrink it so that it fits into the skull space. The other thing we can do, so maybe we can't prevent, or they're not handling the mannitol, they can't handle the dehydration anymore, their blood pressure's too low, we can't keep their blood pressure up, we can't keep their MAP up, so they don't want to do mannitol any longer. Then we're going to have to physically go, and we can't, we're not going to remove brain tissue, we're not going to remove blood flow, but we can remove CSF. We don't really need it. It's a cushion for the brain. If the patient's in severe distress or increasing ICP, the next most invasive is to remove the cerebral spinal fluid. And that is where they put the drain into the ventricles and actually drain out CSF as it's being made. Like basically the patient will not have CSF anymore. Do you think they'll have a headache? Well, heck yeah, but they also have increased intracranial pressure and a worsening neuro exam, so their headache is probably the bottom of our list right now. If they have not responded to the osmotic diuretic, then they are probably so brain swollen that they're not really working on the Glasgow Coma scale. They're not awake, they're not alert, they're not conscious. We're going to be removing cerebrospinal fluid in order to maintain an ICP. And if that doesn't work, where we have had the ventricles are completely collapsed, you can see on this patient, let me see if I can blow up this picture down here at the bottom again. I'm going to blow up and show you this bottom picture. This is a patient pre and post decompressive craniotomy. So you can see here, I can see a couple of things have happened. You've got a huge bleed right here. This is all blood. Let's look at our midline. There is no symmetry on midline there. In fact, I'm not even seeing the butterfly. We're really, the ventricles are getting compressed here, and you can see how the whole brain is kind of shifted over to the side, and basically it's already compressing the ventricles. At this point, what they did was they went in and they ended up removing the skull. This is actually brain tissue right here. That's the edge of your brain tissue. They have evacuated all that blood. They took that blood off the top of the brain, and the brain is now swelling out. These are actually, this right here is meninges. They've taken the skull off here, and this is meninges. And they're allowing the brain to, this is probably not the best color for drawing on black. They're allowing the brain to swell out this way. So they've given it an out other than the spinal cord. And so it's better to take off a piece of your skull and let your brain swell outwards than it is to herniate and die. So that is the probably the most invasive thing that you will do to see them. Oop, I didn't mean to close out my whole PowerPoint. That's probably the most invasive thing that they will do to save a brain. Is the decompressive craniotomy. So they might try to remove CSF for a while, but if the brain is swelling so quick and so fast that it is looking like herniation, they may go in and take a piece of the skull. And that is to allow the brain to swell out of an area other than the spinal cord. It basically relieves pressure on the brain. So that is an option for patients. And so it's basically least invasive to most invasive. They will try to maintain neutral neck, head of bed up. If that's not working, they add the osmotic diuretic. When the osmotic diuretic does not work, they'll put in a drain to remove cerebral spinal fluid. And then if that's not working, they will go in and remove a piece of the skull to allow the brain to expand. Does that make sense there? So you may see people, they may decide to go in if the brain injury is big enough and they know the brain is going to swell and there's nothing they're going to be able to do, they may go straight to a decompressive craniotomy. And so I don't know if you've worked with any patients. If you go to Barrows and work with any of the patients there, you may see patients that have post-brain injury and they have that piece of the skull removed and they're wearing a helmet afterwards. Because once the skull is removed, you have no protection on your brain. What they usually do is they take the piece of skull out and put it in your abdomen so that it remains nourished and doesn't die, because the skull is a living bone. It needs nourishment. It needs blood flow. And so they store it in your abdomen, or sometimes they take it and freeze it somewhere. But they do store your skull for putting it back on later. But basically they do remove a piece of the skull. And that is better than dying of brain death. If they can get you in there to do that. And then what we're trying to do, your dad had a drain after the accident, but not the craniectomy. So the drain then was maintaining his inner cerebral pressure at an adequate level. The drain usually does, if we can get all the CSF, then we've got room for the brain and the blood to go in there. So I don't know, if you've had experience with all of this stuff, this might be making sense to you, hopefully, why they did what they did. The other thing we're going to do is we're going to let the brain rest. So we are maintaining oxygen, we're maintaining perfusion, we are decreasing the intracranial pressure, and we're letting the brain rest. Complete brain rest the best we can. Decreasing stimulation, this works for any, even if you don't have increased intracranial pressure. Decreased stimulation if you have a migraine, if you have a concussion, if you have any kind of skull fracture, any kind of damage to the brain, it's going to hurt. And so decreasing stimulation, they also call it concussion rest, where you're not allowed to eat. You're not allowed to read. You're not supposed to watch a lot of screen time. That's to decrease your brain firing. And I had to go through this with my daughter. She just had a concussion, and I had to tell her, I'm like, well, you've got to sit. She's like, I'm bored. And I'm like, I don't care that you're bored. Your brain has to rest. If you're stimulating your brain, you're causing firing, and it's going to cause your worsening headache. So dark, quiet environment. This includes the hospital. Neuro patients are usually neuro units are usually left kind of dark, kind of quiet. Reduced visitors. cluster your patient care. You don't want to be having the lights on and in the room all day, all night. The brain will continue firing. If it's getting stimulated, it's firing, and that can cause more swelling in the brain. So we want to decrease stimulation, keep the fever down, decrease the metabolism for the brain. Pain control is going to be non-narcotic. No matter how crazy your patient is acting and how out of their neuro exam they are, you're not going to get narcotics for a brain disorder patient. No narcotics, because that will dull the neuro exam. It does change your neuro exam, and so you're not going to get narcotics from any neuro doc at all. They hate narcotics and will not give them to you. No narcotics, no benzos. They are usually managing pain with Tylenol, muscle relaxants, if we do need to sedate them with things that are reversed quickly, and so that we can do our neuro exams. But you don't get narcotics for neuro patients. So if you have a test question and it's asking you about pain control and you pick the narcotic, no. So if you like to give out narcotics, don't go work in a neuro unit, because you won't get them. It does dull the neuro exam, and the neuro exam is too important. Antimicrobial therapy, again, we don't want any kind of infection, so most patients with any cranial disorder will be treating infection soon, looking for signs, symptoms of infection, and treating those infections before they become inflammation. If the ICP is increasing, if you're having increased ICP or worsening symptoms, then they want to prevent any seizures, any brain firing. We may need to, sometimes the patients do get put into a coma with barbiturates and paralytics. And again, that's just to basically shut down the brain from firing at all. Will it affect our neuro exam? Yes, it is. They will do some sort of neuro monitoring if you have paralyzed the patient, in order to be able, you will either be measuring the intracranial pressure directly, or you'll be monitoring brainwave activity if you sedate a patient, because you've lost your neuro exam as soon as you paralyze them. But it may be necessary to get the brain to shut down enough to stop swelling. Again, the more it's being asked to do, it's like the heart. It can't stop. So we ask a lot of the heart when it's damaged, and we sometimes have to support it mechanically. There's nothing to support the brain mechanically, so we are going to be, sometimes we do have to say, all right, enough is enough. We need to shut you down so that you don't swell anymore. And they will put a patient in a medical coma to make the brain stop working, because working is causing swelling. And if that does happen, then you are usually, we do need to monitor, so I'm just going to write that off to the side. You lose the neuro exam, and so we will monitor ICP directly or monitor brainwaves. And I'm not going to teach you that because it's just too much. They can also put the patient into moderate hypothermia, not the deep, dark, severe hypothermia, but moderate hypothermia like they would after cardiac arrest, because again, that will slow down your heart rate, your respirations, your breathing, and your brain activity. So there are two options to, but both of them do require sedation, and so you will need to have ICP monitoring or some monitoring of your brain waves, because if you are sedating a patient or putting them in a coma or induced hypothermia to save the brain, we'll have to monitor their brain function some other way. And then, of course, maintain blood glucose. I don't mean high, but the brain needs glucose for its activities. So we're going to keep that blood glucose right around 100 to 140, not too high, not too low, and maintain that glucose. So if they need to be eating, then keeping that up. This is not the time to starve a brain. Any starving the brain's going to cause more damage and swelling. So maintain the glucose.
Okay, everybody, we're going to stop here for a second and create a little study guide. You may listen along, or you can open up your computer or your iPad and create this study guide with me. I think that typing it in, writing it in, or just even listening 2 or 3 times will help cement these key points into your brain. So I'm starting this with a 5x5 table, 5 rows across, or 5 rows down, 5 columns across, and we are going to sort out our 4 major major problems that happen between spinal cord injuries and brain injuries, and we're going to help you sort this out and keep all this data separate. Just another way to help you study. So the first thing we're going to do on this grid is look over and summarize Cushing's Triad, which goes along as signs of worsening intracranial pressure. Again, this is the only sign, this is the only problem that can happen. It is the worsening cue for all head injuries. Any injury of the skull or the brain inside the skull is going to lead to a possibility of a worsening cue of increased intracranial pressure. So some head injuries never develop increased intracranial pressure. Some head injuries develop very big problems with increased intracranial pressure. So we are always looking for, with neuro injuries or any kind of neurological problem, we are looking for cues of increased intracranial pressure. So there are 3 vital sign cues of increased intracranial pressure that we are looking for as we trend our vital signs. That will include an increased blood pressure to the point of hypertension. This is a trend, so you notice your blood pressure increasing and increasing and increasing throughout the day. It can be a slow, gradual increase in your blood pressure. It could be a sudden increase in your blood pressure, but it's an increase in your blood pressure along with a decrease in your heart rate to the point of bradycardia. So we will see a trend, again, either gradual or sudden, depending on how fast the intracranial pressure is developing, that you will have an increase in blood pressure along with a decrease in heart rate. That is not a normal finding. That does not normally happen. When that does happen in the face of a neuro injury, we consider that we might be having increased intracranial pressure. It usually coincides with a decrease in your neurological exam or your Glasgow Coma scale score. So we see this increasing blood pressure, decreasing heart rate, and along the way your respiratory rate decreases overall, but also becomes irregular, where they will have long periods of no breath, and then short periods of quick, fast breathing, and then long periods of agonal breathing. It's called Cheyne-Stokes respirations, but overall it leads to a decrease in respirations. What are we going to do for increased intracranial pressure interventions? We just looked at this, but I'm going to summarize it quickly for you. I'm also going to separate it into nursing and ordered interventions because I think that helps. The quick, easy things we can do, or first items if we see increased intracranial pressure or are suspecting increased intracranial pressure, we're seeing a drop in the Glasgow Coma scale, we're seeing the Cushing's Triad trends, we are going to ensure that our patients have maximized O2. We're going to do this anyway. We're going to make sure our patients have an oxygen percentage of 80 to 100. This is a general good idea for all patients. Nothing new. Maintain your airway. These are not the patients. These patients are not as with it. They're having a declining neurological status. They're having vital sign changes. They're having increased intracranial pressure. They can't control their airway as well. They have possibly you could hear gurgling in the back of their throat. Possibly they are having snoring respirations. They are not breathing as well as you would like them to be. We're going to have to ensure that their airway is open and patent. We want them getting as much oxygen in and out of their airways as possible. Keeping secretions out of the airways. These people have weaker coughs. Their neurostatus is declining. They are not able to care for their airway, and that becomes our job to encourage their coughing, deep breathing, chest PT, turning them side to side, helping them cough up their secretions. In terms of perfusion, we need to ensure that the brain gets all this oxygen up to the head that we're ensuring they have. So to ensure the oxygen gets up to the head, as a nurse, we're going to make sure that their head of the bed is upright. If you lay the patient flat or put their head down in Trendelenburg, all their blood flow is going to stay in their head, increasing intracranial pressure. So we want patients to sit upright as high as they can sit and tolerate in the bed. That provides drainage. We're going to also keep the neck in neutral position so that our carotid arteries and our jugular veins are not constricted in any way. We want our blood vessels going up and out of the brain to be able to provide blood flow up and allow drainage out of the brain space to maximize perfusion. We do have more interventions again, but I'm separating these out into what we can do as a nurse without an order and what we need to do with an order. So some of the other things we can do without an order on a head injury patient or a patient we're worried about increased intracranial pressure on, we're going to darken and quiet their room, decrease the stimuli. Even a patient who's not responding to us or has a low Glasgow Coma scale, their brain is still trying to sensory process. So if we decrease the sensory that they're hearing, noises, arguments, beeping, buzzing, it allows their brain to rest. And you know, if you've ever had a headache, you don't want a lot of noise and commotion going on around you. Your brain needs to rest. Quiet, dark, decrease stimuli. Don't go in your room every 10 minutes to do a procedure or forget something. These are patients that need probably a good half hour of rest in between bothering them so their brain can quiet down and drop the pressure. Those are nursing interventions. Now we'll just summarize our medical ordered interventions for increased intracranial pressure or seeing Cushing's triad develop. In terms of what we can do as a provider to, or advocate for our providers, for our patients, is we can only do so much as a nurse to maintain their perfusion. We may need to artificially elevate their blood pressure a bit to get pressure up into that tight brain space. So you can keep this minimum map of 60, but that is for normal patients without a head injury. Once your patient has developed a head injury or has a risk of increased intracranial pressure or actually has increased intracranial pressure, we are now changing our minimum map to 70. This will overcome any ICP of at least 10 or higher. We want a mean arterial pressure of at least 70 in our neuro-injured patients. We also want a maximum mean arterial pressure of 100. We don't want too much blood getting up to the brain space, and we don't want too little blood getting up to the brain space. And we may need help from the physicians or orders from the physicians in keeping this expectation. How do we keep blood up to the brain? How do we pump it up higher? Fluids, vasoconstrictors. These things will increase our mean arterial pressure. If our mean arterial pressure is too high, we will need to decrease that mean arterial pressure with a vasodilator. So we may need to advocate for our patient if we see our maps are not between 70 to 100 on a neuro-injured patient. Let's get there so that we ensure a cerebral perfusion pressure for our patient. What else can we do to decrease intracranial pressure in terms of ordered interventions? Well, if we are still seeing signs of Cushing's triad or a decreasing neurostatus, when we've done all of our nursing interventions and maximized perfusion, now we need to increase our intracranial pressure management. We will first try mannitol, which is a strong osmotic diuretic. It will dehydrate the brain and make you pee more, but remember, we are assessing our effectiveness of the mannitol dose by rechecking our neuro assessment on our Glasgow Coma scale and our increased intracranial pressure values, if we have them, to make sure that we are decreasing the pressure in the head. We should see an improvement in our neurologic status. We should see an improvement in our intracranial pressures if we're monitoring them. If mannitol is not working and we're not monitoring our intracranial pressures, this is the time to do it. If mannitol is not effective and we are wondering what exactly is the pressure in our head, now is the time to put in the monitor or the drain into our brain space. This will ensure that we are monitoring our intracranial pressure and that we could drain out cerebrospinal fluid if we need room in the brain space. We can't drain out our brain. We do it the best we can with mannitol, but we cannot remove any brain tissue from the skull space without causing permanent damage. We also cannot remove too much blood from the brain space, because we need that blood circulating around our brain to provide oxygen and ensure our brain continues living. So cushion is what we can remove without removing a vital part of our brain function. So if we need to remove any fluid out of the brain space to accommodate a growing, swelling brain, then what we will do is remove cerebral spinal fluid, but that requires a cerebral spinal fluid drain called a ventriculostomy. And then if those interventions don't work, then they will consider removing a piece of the skull and doing a decompressive craniotomy to allow a pressure valve outlet for the brain to swell during this increased intracranial pressure interventions. So that is a summary again of our interventions. I'll let you move forward into the additional interventions for a few things like basilar skull fractures and aneurysms, but keep the sheet going. We will come back to it in the spinal portion of the class.
So now we have a couple of additional interventions, and again, I'm sorry, I know it's running late. I am recording all this. I'm going to finish up this lecture and then I'm going to let you go. But then I'm going to record the spinal lecture and post that in your module so that you have it for later on. Basilar skull fractures, again, if you have battle sign, raccoon's eyes, any CSF drainage, we do have a couple of specific things on top of everything you're doing, those 5 interventions from before. No NG tubes. Oral gastric is okay. You can put a tube down the oral to the gastric, but you're not going to put it... Does everybody see the picture up at the top there? This is why there's no NG tubes, because if you have a fracture at the base of your skull and we are shoving a tube up your nose, it can get through the fracture and into the brain. So no NG tubes. You could Google NG tube in the brain and find tons of CT scans where the NG tube has ended up in the brain. So no NG tubes, nothing nasally. You can do an oral gastric tube if you have any raccoon's eyes, battle sign, CSF leak, any drainage, clear drainage after a head injury from your nose or your ears. If you have an order for an NG tube, do not put it in nasally. You have to go in orally. Because you have a sign of a basilar skull fracture and you don't want NG tube in the brain. You don't want to be the nurse that did that or the doc that did that. So don't put an NG tube in, even if you have an order for it. Ask if you can do it oral gastric because you have signs of basilar skull fracture. We don't want a lot of sneezing or blowing of nose. We let the drainage kind of run out. Put the gauze, again, this is CSF, it's not sinus drainage. So we don't want to be increasing sneezing or blowing the nose, increasing pressure, and then we're just blowing more CSF out. So just tell them, yes, you have a basilar skull fracture, you may have a drainage from your nose, just wipe it, blot it with gauze, and keep an eye on the headache level, because depending on their drainage, you would want to test the drainage to make sure it is CSF. You can send it off to the lab for glucose content, check it for halo sign, but make sure that any patient that has a CSF leak is getting adequate hydration. Because we make CSF on our own, just like we make urine, just like we make secretions. We're going to make CSF at a rate of 2 to 10 milliliters an hour, but if they are draining 20 milliliters an hour, they're going to end up in a CSF deficit and a severe headache. So make sure they get adequate hydration so they're producing CSF to replace the leak. And certainly let the doc know if the leak is getting worse or that they're using more gauzes. You'd want to keep an eye and somehow quantify that CSF leak if you can. Just so that you have an idea of how much is leaking out. Again, we will make it, we'll remake it, but if your patient's having a worsening headache after a basilar skull fracture and their drainage is increasing, that could be a sign of increasing CSF drainage, and may need some intervention from the doc. They can do what they call blood patches, where they can patch a CSF leak. So there are interventions for it. So just let the patient, thank you. Sorry. I apologize. Obviously I'm talking too long. My microphone's telling me to take a break. But I want to just get through these real quick and let you go. So try to quantify your CSF drainage, maybe, a gauze every 4 hours or something like that. But try to quantify it so that you have an idea of how much CSF is being drained to see if it needs to be an intervention. And we don't, again, want anything that's going to increase our intracranial pressure. Sneezing, coughing, gagging, vomiting, all that stuff's going to make your CSF leak worse, because when you do all those things, you transiently increase your intracranial pressure. Think about a sneeze, how much pressure goes on in your head if you have a sneeze. If you're gagging and coughing and throwing up, that's a lot of pressure in your head. And while the pressure in your head is high, CSF will be leaking out. So all those things increase your CSF leakage, so we want to minimize them if we can. Brain bleed, really, you're just going to be doing those 5 interventions. But if the bleed is on top of the brain, like this one is here, this bleed is, I wanted to draw. It's not letting me draw. This bleed you can see right here is sitting on top of the brain. They may be able to go in and evacuate that out if it's causing a midline shift, which is what we see on CT scan. This is a shift off of midline. And so if you have an epidural or a subdural that's sitting on top of the brain and causing a shift, they may go in and physically remove that blood clot in surgery. But otherwise, you're just going to be maintaining your 5 interventions for cranial disorders. Meningitis, the big king on meningitis is they're supposed to go into respiratory isolation until the lumbar puncture has disproved bacterial, because we assume bacterial because it's the worst one. If you're coming in with Kernids, Brudinski's, nuchal rigidity, then they're going to go on respiratory isolation until a CSF analysis is done and read. Then once it's confirmed viral, you can take them off isolation. If it's confirmed bacterial, they'll continue respiratory isolation. That's the big keys on meningitis. And cerebral angiogram, again, a cerebral aneurysm or AV malformation, we want to keep the blood pressure lower than usual. We want to maintain perfusion to the brain, but we don't want hypertension. Avoiding hypertension or high MAPS causes these things to break. It's already a fragile blood vessel. And so they want to control the blood pressure, hypertension control, the same as a aortic aneurysm. It's hypertension, a lower blood pressure, avoiding hypertension, but we still want to maintain, remember, our cerebral perfusion. We want to avoid any blood thinners, and then there's a couple of interventional approaches where they can go in. It is a interventional procedure, femoral procedure, and they will inject things into sclerose or clot off those aneurysms or malformations to prevent them from bleeding. If you find them, a lot of times the only time they find them is after they burst. So again, if you're having localized symptoms, they will go in and do a couple of interventions to clot off or fix those abnormalities so they don't bleed. And tumors, the thing I'm going to say about tumors is that surgical removal is the best way to remove them. It does involve removing some of the brain around them to get clean margins. And then radiation and chemo is a follow-up. But usually IV chemotherapy does not cross the blood-brain barrier as easily. So if the chemotherapy that is effective does not cross the blood-brain barrier from the IV route, they may go ahead and put chemotherapy directly into a ventricle and let that chemotherapy circulate around the CSF space. And that's done through a reservoir where they physically put a drain or a catheter into the ventricle there and have a port that they can inject chemotherapy through. So you may see something like that on a brain tumor patient, and that is for giving chemotherapy directly into the ventricle space. You will not be able to access that. Only a physician or advanced practice nurse would access that reservoir to give chemotherapy. Cranial surgery, again, very, very basic. This is not, you're not qualified to take care of brain surgery. Well, maybe you are taking care of brain surgery patients. But we do expect drainage devices after brain surgery. Sometimes they're just, they're subdural, where they just drain. Again, most surgeries have drains associated with them afterwards. Brain surgery is no different. If it's not in a ventricle, it's not going to drain CSF. So you could have any variation of drainage devices in there. But what's important to find out is it in the ventricle or not? Because if it's in the ventricle, it would drain CSF. If it's not in the ventricle, it's just draining wound drainage. All your cranial disorder interventions are expected to be doing maintaining oxygenation, perfusion, doing a neuro assessment, decreasing ICP, and brain rest after brain surgery. Don't expect increased intracranial pressure. And so if we do see any of those things, then we'll have to go to the higher, notify the physician, go on to the higher interventions for decreasing ICP and maintaining brain rest. We don't expect a low blood pressure because, again, we need cerebral perfusion. We don't expect too high of a blood pressure because that could cause bleeding in a surgery that's been done on a brain. And we don't want hypoxia or infection.